Niranjan Chavan and my dear friend Dr. Ritu Hinduja on this very interesting webinar on robotics and RPL. The conveners of the program is Dr. Komal Chavan. Have a CV, please.
Video be played and the inaugural video. Site. We'll introduce you, Sheetal.
Yeah.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Good evening, everyone. I'm Dr. Maunika, Medical Advisor from Shield Healthcare. I welcome you all for today's session, A to Z task series by AGOG. And I would like to welcome our coordinators, Dr. Ritu Hinduja ma'am and Dr. Sheetal Savankar ma'am. And Dr. Ritu Hinduja ma'am, she's an MD Obstetrics and Consultant Fertility Specialist in Nova IVF, Mumbai. And Dr. Sheetal Savankar ma'am, she's an MBBS DNB, MNAM, FICOG, and she's a Director, Avisa IVF and Fertility Center, Mumbai, Consultant Surya Fertility Clinics, Mumbai. I hand over the session to Dr. Sheetal.
Hi, thank you so much. And this is a very interesting series about robotics and RPL. Both of them are very interesting topics. As we know now, we are in the era of artificial intelligence and baby buds. So we need to know a lot about robotics, and RPL is a very difficult topic for obstetricians as well as IVF consultants. So we are going to throw some light on these interesting topics. And now to go on the conveners of the program, the very interesting and the dynamic duo, Dr. Komal Chavan and Dr. Niranjan Chavan. Dr. Komal Chavan is the Medical Director of Chavan Maternity and Nursing Home. She's a Senior Consultant, a DNB teacher, and the Unit Chief of VN Desai Hospital, Mumbai. The next convener, Dr. Niranjan Chavan. Ritu, you want to introduce him?
Sure. Then Dr. Niranjan Chauhan needs no introduction, of course. He is the president of MOGS, the past president of MOGS Society. He's a professor and unit chief of LTMMC, Sion Hospital, and a joint treasurer of Foxy from 2021 to 2024. He's loved and respected by one and all in our fraternity. And he's not only just loved, he's also a very strong guiding force. So thank you, sir, for joining this program, and thank you for guiding me and Sheetal to conduct this program so efficiently. Now I'll hand over the platform to Dr. Komal Chauhan and Dr. Niranjan Chauhan to please say a few words for our.
Just one more thing, if I can add. Sir was responsible for me to get into IVF. So yes, that was also one thing that I wanted to add on.
Thank you. Thank you so much, Ritu and Sheetal, for your kind words. You are the future of MOGS and Foxy, and we look forward to see you also in that position as what we are today. It's a question of time. Thank you.
Thank you. Thank you so much, Sheetal and Ritu. Thank you all esteemed faculties for joining, and all the delegates who have joined. A warm welcome to one and all for this trending Ask the Expert series under the aegis of AGOG. And today's episode, Robotics and RPL, that is episode R. And definitely we need to move with time, and robotics is an in thing, though we have advances in infertility that we have our esteemed chief guest and guest of honor present. Dr. Kamini Rao is the chief guest today, and she is the founder chairperson of Mediline Academics an e-learning portal. We know Kamini Rao as the past president of the prestigious organization FOXY, and she's also the editor-in-chief of the International Journal of Infertility and Fetal Medicine, and national member of the National Advisory Committee for drafting guidelines on ART. Padma Shri in 2014 in recognition of the distinguished service in the field of reproductive medicine. And she's also received honorary fellowship of the International Academy of Human Reproduction, based on the contributions in science and human reproduction, and recognized international prominence in May 2021. I think she has done so many changes when she led the FOXY organization. We have Yuva FOXY, which was started in her year, and Kamini Rao Yuva Orator, which is there every year. So a lot of work is done, and we really are very proud that we know Dr. Kamini Rao. She is associated with FOXY, and it is really honored that Madam is present here as chief guest. So over to you, Madam, to address the audience. You unmute, Madam.
Thank you very much, Komal and Niranjan, for inviting me for the task series. And I think it's a wonderful way of disseminating knowledge. And what better than in the 21st century to have robotics and RPL, because this is an era where the more you learn, the less you know. And robotics is here to stay with artificial intelligence, getting into every aspect of IVF. And I'm sure this entire session is going to be an exhilarating one, because at the time when I was in FOXY or president of ISAR, we didn't have so many webinars, but the present day generation is lucky to have everyone disseminating knowledge in such an easy manner in the comfort of your home. And I'm sure this session is going to be as good as any other. I wish this webinar all success, and I'm sure Shield Healthcare is doing a yeoman service in providing this kind of a platform for all our gynecologists. Thank you, Komal. Thank you, Niranjan, for giving me this position of chief guest. Thank you.
Thank you. Thank you, Madam, for your lovely pearls of wisdom. We are really honored and blessed. And thank you. And now I request Dr. Niranjan Chauhan to say a few words.
Thank you, Madam, for joining in spite of your busy schedule. We are really honored to have you. And yesterday only one of the book, seller has sent me the set of 1 and 2, Kamini Rao's infertility book, Madam. And it's like a Bible, for all the students, postgraduates, and also to the consultants. See, knowledge, Madam, is it is never ending, and how much ever you age or you have experience, really all infertility consultants, I'm sure they are having your book, Madam, and that's the contribution which you have given to all of us. And really, we are grateful to you for joining us today, and really honored. Thank you, Madam, so much.
Thank you so much. And now I call upon our guest of honor, Dr. Sunita Tandulwalkar. Sunita Tandulwalkar, we all know, is head of the Department of OBGYN, Chief IVF Endoscopy Center at Ruby Hall Clinic, Pune, Advisor Consultant, Dr. G.Y. Patil IVF and Endoscopic Center, Pune, and she is the founder, Medical Director of Solo IVF Clinic, Center for Excellence in Infertility, and so many achievements to her credit. Extraordinary achievement, that is India's first stem cell baby, world's first at the age of 45, the baby. So all that, lot of achievements. She has also head the Pune Obstetrics and Gynec Society as a president. Then she has been the senior vice president of ISAR and also the vice president of FOXY, and authored 8 books and 29 publications. And she's really a lovely person, real great human being, and I'm really love talking and listening to her. So over to you, Madam, to address the audience.
Thank you, Komal. Thank you so much for having me over here. And I really wish all the best for this lovely. I think so many webinars are happening, but robotic and RPL R square, I have not seen in any webinar. I felt you did a lovely combination. And I have seen so many fertility enhancing surgeries, webinars happening from IAG side, from our Foxy side, from ISAR side, but robotic fertility enhancing, probably I'm seeing it for the first time. So obviously, you are bringing something new on the platform here. Endometrial receptivity by Jyoti, I'm sure everyone will enjoy that. Ruma, your surgeries will be worth watching. And then you have a panel discussion. What I realized is you have taken everyone who are more than 10 years in a practice, but less than 25 years in a practice, so that they are well-read people. And you have taken all these young clad who are my favorites. So your today's topic and your chairperson, whether it is Anshu, whether it is Raki, whether it is Selva and Tripti, everyone, the young clad is absolutely with you. And I'm sure they all are working with me also. They have worked with me before. They are working with me now, and they will work with me in future too.
Ma'am, thoda credit to the coordinators also.
Coming to it, I'm coming to it. About it, you got two lovely girls, Sheetal and Ritu. They are epitome of perfection. Kalyan, I'm just joining in 5 minutes.
Yes, ma'am.
Ritu and Sheetal, the way they communicate, the way they are after your blood to give you whatever they want and reminding in that group, it's amazing. Yeah, it's amazing task. And as Niranjan said, they are the future of MOGS and Foxy. I see everyone in today's your flyer, everyone is leader. I think India is full of young generation who are the leaders. And that's because they are perfect in they're balancing their family life, their practical, their professional life, and the organizational life. And that's wonderful. I wish you all the best. And I humbly request you to ensure that all of you have checked your phone numbers on a member.foxy.org site and be thrilled to vote for the right candidate. Thank you.
Thank you. Thank you so much, madam. I really agree with you. We have our very dynamic coordinators, Dr. Sheetal and Dr. Ritu. And and actually, when I spoke to Dr. Ruma Sinha for the talk about robotics, she said, yes, our episode are for Ruma, are for Ritu. I said, Ritu will call you, like coordinate. She's saying all ours are together, and I have R for Rakhi also here. So, so I think it has become such a coincidence. And thank you so much.
You all lovely, Anshu.
And ma'am, I would like to say that for right to vote, right people to vote are here in this webinar.
Yeah, right to vote.
You should vote for.
Yes. Yeah, and exercise your right to vote also for the right people.
Yes.
Yes. So I think, thank you, madam.
Just joining the other webinar. Thank you, dear.
Thank you so much, ma'am.
Thank you.
Thank you, Dr. Sunita, madam. And it was really great to have you. Of course, and we wish all the best to both of you for the forthcoming elections of Foxy and full webinar now. Thank you, madam. See you soon.
Thank you.
Thank you. Thank you so much. And I'm really honored that we have our esteemed speaker, Dr. Ruma Sinha and Dr. Jyoti Buddhi. And I can see Dr. Ashish Kade and Ashwini Kade also who have joined with all the esteemed chairpersons. So let us start the scientific program and I hand over to Sheetal.
Yeah. So after such amazing words by Dr. Kamini Rao and Sunita ma'am, now over to the scientific session, which is very, very interesting. The next talk is on fertility enhancing surgeries, the role of robotics, and the chairpersons for the same are Dr. Anshumala Shukla Can I have a CV, please? Dr. Anshumala Shukla is the head of minimally invasive gynecology surgery and a laparoscopic and a robotic surgeon at Kokila Bay in Dhirubhai Ambani Hospital. She's done her fellowship at MIS St. George Hospital, Sydney. She's also a postgraduate teacher in OBGYN. And what else can we ask for a talk on robotics? Dr. Anshumala Shukla. Can we have the next chairperson, please? Ritu, do you want to take it?
Dr. Rakhi Singh. Dr. Rakhi Singh is not only the most dynamic faculty in Foxy, but also a very dear friend. She has been a very senior who's always guided me through these societies, and I have a very strong connection with her. She's a director at Abalone Clinic Maternity and Fertility and IVF Center at Noida. She has been a chairperson of Endocrinological Committee of Foxy and a vice chairperson of UP State SR. Welcome, Dr. Rakhi, and thank you for being a part of this webinar.
Thank you, Ritu.
I would request the chairpersons now to please introduce the speaker and take this session forward.
Thank you, dear. At the outset, I would like to congratulate Komal and the whole entire team who's working hard with this A to Z series, and our wonderful speakers which have been come inside with the pearls of wisdom. And we have got Dr. Ruma Sena to educate us at length today with the robotics. She is a senior consultant gynecologist and laparoscopic surgeon and robotic surgeon at Apollo Health City, Hyderabad. Founder president for the Association of Gynecological Robotic Surgeries, pioneered robotic surgery in India since 2012. Today, she has done maximum of robotic myomectomies among the other robotic surgeries, an honorary professor AHERF and co-joint associate professor at McQueen University, Sydney, Australia, recognized as a distinguished clinician at Apollo Hospital since 21. An area of special interest is minimal access to the gynecological surgeries, that is laparoscopy, hysteroscopy, and robotic surgery, non-descent vaginal hysterectomy, urogynecology, and pelvic reconstruction. Who else could have done the justice to this topic of fertility enhancing surgeries other than Dr. Ruma? Over to you, madam.
Rakhi, thank you, and good to meet you online here.
Definitely same.
So I would really thank Komal and Niranjan for giving me this opportunity to talk with an interesting group of people who are dealing with infertility. Sheetal and Ritu, thank you for saying and thinking that, yes, we need to talk about the future technologies. We need to talk about how robotics is changing our surgery, how we are talking about artificial intelligence, VR, augmented reality. It is not something which is science fiction anymore. It is integrating into our day-to-day activity and in day-to-day medicine. All we need to is remember that we have to deploy it responsibility. Let me start sharing my screen. Just give me a second and I will talk about.
Madam, welcome. Ruma, madam, welcome. And
Niranjan ji, hi, thank you.
Yes, madam. Before you start the lecture, I would like to thank you from the bottom of my heart for all those robotic lovers. You are the epitome of robotic surgery and really done a lot of works. And I am really grateful to you for being associated with all those webinars in COVID times where we had Adventula and Gabby Moore and so many people who were there, the pioneers. And now things have gone really, really great. So thank you, madam, for coming today and, enhancing the knowledge of fertility, enhancing surgeries. Thank you, madam.
Thank you so much, Niranjan and Komal and the AOGD, so who actually are conceptualizing and putting up this series. I actually, before I start my talk, I know there is a increase in interest in robotic surgery across the country in gynecologists. So I begin my lecture today by inviting you on 12th and 13th of August for our second RoboGyne India. We had one last year in August 2022, which was our inaugural meeting of this association. This time we are again having it in Hyderabad on 12th and 13th. And you spoke about Arnie Adunkola. He'll be here with us. He's actually this time giving us the first AGRS oration, to robot or not to robot. And there are other faculty, 2 from Asia, 1 from Singapore, 1 from Seoul, and Dr. Tony Chalap from UK, who will be taking the master class on endometriosis in robotics and endometriosis. So do join us. All those enthusiasts, especially I heard Sheetal and Ritu talking about it. Please join us for this, because the talk I'm going to give, you'll realize how important it is for you. So what is the scope of my talk today? Why discuss reproductive surgery? Role of reproductive surgeon. Why we talk about minimal access and how we can integrate it to the robotic platform today. What is it in a name? Is it a robotic surgery? Because patients will ask, ma'am, aap karenge ya robot karega? It's just a computer assisted surgery. So that's what we need to remember. It's actually at the moment a telemanipulator. That means you're sitting at a distance from the patient and manipulating your instruments with the assistance of the computer. Now you need to understand why we need MIS in reproductive surgery. Now we understand that MIS is always done in closed peritoneal environment. There is decreased peritoneal abrasion, tissue injuries less, foreign body reactions are less, and we operate in magnified vision, intra-abdominal, high intra-abdominal pressure. So improved visualization, better hemostasis. So at the end of your surgery, I have only 2 things that you must remember. There should be good tissue appropriation and good hemostasis. You will go and operate those patients, you will find not a single addition. I don't think it's the laparoscope or the robotic platform that does that. It's your meticulous surgery that matters. And I can tell you many of my associates and juniors will swear by it, that when we do these myomectomies and endometriosis surgery and they go back for a cesarean section later, there is not an iota of additions there. So advanced ART procedures are well known. All of you are doing it. But remember that surgery plays a very important part in the component of the management of an infertile female. Although not the immediate pathology, so like fibroid, tubal pathology or endometriosis, but ultimately attainment of healthy maternity, surgery can play a role. It should be minimalistic and carefully targeted to the right patient with the right procedure. And of course, with this, you need to have a deep knowledge of endocrinology, the pelvic anatomy, and to execute effective reproductive surgery. So who is the best person to perform the reproductive surgery? And I believe it is not a routine gynecological surgeon and definitely not a general surgeon, because they do not understand what to save and what not. So the subspecialists, you who are doing the reproductive work for women, should tailor the time and extent of the medical, surgical, ART interventions unique to each patient's requirement. So I think if you are looking at ART work, you must also be ready to do your myomectomies, should also be ready to do your endometriosis, because you're the right person. You'll take the right choice, the right call for that patient, rather than sending it to somebody else. So not unusual to delegate your reproductive surgeries by fertility specialists to other surgeons. And then you will definitely avoid to do an open surgery. A classical example, let me just make this for you. Now you have a patient who is 38 years old, nulli gravida, AMH 0.6, bilateral endometriomas, as you can see. There's a left hydrosalpinx, there's an adenomyoma at the fundus, which is 3 and 4. You name it and she has everything. She also has a heavy menstrual bleeding, dysmenorrhea. She desires a pregnancy. Now, what surgical intervention would you like to do here? Depends on the surgeon in charge, right? So you send this patient to a surgeon and the surgeon is referred by a fertility specialist. So there are 2 options for this surgeon. What is a reasonable approach? Remove the hydrosalpinx, strip both the endometriomas, do adenomyomectomy, excise the endometriosis suspected. So the surgeon will methodically go from one point to another and do a complete surgery. But what I would suggest is the ideal approach. Eradicate the pelvic pathology 100%, preserve the ovarian follicles, which as a reproductive specialist, you will really understand. And of course, then rapidly enroll her into an ART program. While a patient moves from reproductive unit to a surgeon's unit, goes back, 2-3 months is lost. If you had managed that patient yourself, you would have made much better. This is not unusual to find IVF clinics today crowded with women who had lost their last cohort of oocytes by overzealous surgeons and laparoscopic, who had just laparoscopic sticks and skills. They did not understand how to save these oocytes and ovaries. So the fertility specialists have 2 professional choices. They understand and do not want to do open surgery. That's true. You all don't want to do open surgery. So either they devote their clinical time and energy and master to maintain a laparoscopic surgical skill to be able to do stage 4 endometriosis or multiple myomas, or relinquish your patients to skilled AP surgeons and say, okay, I'm sending, do this patient, this 5 points, because often I get these patients and say, this 10 list, this, please do all this, madam.
Well, because I'm a trained gynecologist, I probably respond to them better and I understand the fertility requirement and I do my bit well. But not everybody will give your patients the same. So why fertility specialists are relinquishing surgery? Why are they only doing ART? Because doing laparoscopy, as you can see here, is tough. It gets converted. It's a long learning curve. You're anyway learning ART. Where are you to have the time to learn the laparoscopic skills? So that is the advanced conventional laparoscopy is hard to master. That is where you also have a problem. In laparoscopic surgery, there's another problem which I always talk and discuss with my fellows as well, is gaze disruption. Now, the times that the primary surgeon actually looks away from the monitor to somewhere else contributes to surgical error. One of the study showed that this commonly happens when there is an instrument exchange, troubleshooting, extracorporeal work is going on. And if you look at a small surgery like lap chole, you'll find that 120 times in an hour that there is a gaze disruption. And that's where the surgical errors improve. So more than 8 gauge disruption increases the chance of a surgical error. Practically, it is non-existent in robotic surgery because you're so focused and you do your surgery so focused. That's why we call 2 fertility specialists that come forward, learn this on this platform, and you will be able to do. Because not all reproductive surgeries are possible by laparoscopy, and not all reproductive surgeons are able to do all their surgeries. The advantage of reproductive surgeons are, especially with robotic platform, you have a near control of your surgical field. When I mean that, you can control your camera, you're controlling 3 instruments, you are under so much of advanced vision that you can see even, we laugh sometimes and say you can see RBCs as well. Of course, because of the 3D stereoscopic 10 times magnified vision, intuitive movements. I'm not talking because of this company, the name is intuitive, but it is really intuitive in the sense that you move wherever you want to go, right, left. You are not doing counterintuitive movement like a laparoscopy. And of course, what I as a surgeon over a decade of laparoscopy and robotics have understood is there is a tremor filtration. Now, if you remember and think or watch next time when you are in your theater, at the end of your laparoscopic instrument, whatever it may be, there is a slight tremor. It's possible. I mean, hold a long stick and at the end there'll be a tremor. Or the person who's holding the camera movement is also having a slight tremor. This gets completely filtered by the machine. So if you have a hook or a scissor next to the ureter, you have a large nodule there, you can fire your monopolar with so much confidence, which you can never do with your laparoscopy. And the missing link, of course, is the wrist that you can have. Plus, the robotic platforms are all integrating today with digital simulation, augmented and virtual reality, firefly fluorescence, artificial intelligence. So 5 years' time, as I see, we will even not see the way we are seeing robotics today. It will be a different game plan there. So reproductive specialists, they have the medical knowledge, they can do surgical judgment, technical skill is only that they pick up. So I believe that as a fertility subspecialist, your opportunity to do your own surgeries by robotic platform is here. So how do we do robotics? We do understand that it is not, it's not a rocket science. You put the same ports and then you dock the robot. And then when you dock the robot is holding your ports, you insert the instruments, and then you come down and sit on your console. I'm sure these are pictures which I used to show earlier. Many of you have already seen this in your hospital and theaters. That is the console which you will be sitting. You have foot control, you have hand control. These are called the masters. And this is where the instruments actually inside the patient you are controlling. Every millimeter is you who control, nobody else. So instead of doing, as I give a very common corollary, is doing a Tandav Nritya in the lab theater where 2 hands going this way, 2 foot going this way, you are twisting, you are doing something, you actually become a Durga Ma. You have multiple hands, sit quietly on a console, focus on the problem that you have to solve. And that's how you go. So reproductive surgery, what all can we do by robots? You can do myomectomy, you can do endometrial resection, you can do tubal recanalization, fertility sparing trachelectomy if a patient has an early CS cervix, you can do abdominal cerclage, and of course you can also do orthotopic and heterotopic ovarian tissue transplantation and save the tissues for it. Let's come to something which is my favorite, which is robotic myomectomy. Now, if you look at some statistics, survey of Canadian gynecologists, only 12.7% offered laparoscopy for more often than open myomectomy. Survey in UK, and I'm not even talking about any other country. Survey in UK, 32% felt confident in lap myomectomy, but 74% still performed open myomectomy. So there were cases that they would still do. For me, it was autumn of 2012, which I was introduced to this machine, and I just continued with it for the last 10 years. I thought about where I could fit. I thought about the complex patients, and this is the first patient that I started off. A large myoma who was told open surgery and may end up hysterectomy, but that's what was my giant myomectomy for a small step in adopting robotics for myself. But if you have fibroids in young women, there are two scenarios. They're either symptomatic, so you need to improve their symptoms, or there is a challenge of decision-making, whether to operate or not to operate. And once you decide to operate, you still don't decide to operate. Even if you're offering them an ART, many times a requirement of a normal or a functional uterus is required. So the patient is studied with fibroids. It has a submucous extension. It is distorting the cavity. You do want to remove those fibroids before you proceed, right? So let's see how we select our cases or how we do preoperative management. We actually almost always do with our MRI, and we published a paper in the Foxy journal. What are the 5 steps we actually take, or 5 modifications we have made to make this robotic myomectomy better? So you can have these MRI screens, and you can check where the fibroids are depending upon where you are dealing with. So these are all large fibroids, oddly located fibroids, where you need to understand why you need an MRI is to plan your surgery well, critical optimizing of the uterine incisions, avoid trauma to the cornu, and of course, you don't want to enter the cavity. So these are some of the technical details of how we have changed our trocar placements. I will discuss this with maybe one by one who wants to do this procedure. Just trying to say it's not rocket science. You can do this. We almost always use 30 telescope. One hand, you keep scissors with monopolar current. The other hand, you keep a bipolar fenestrator with a bipolar current. And of course, you use needle driver for suturing. So let me take you through a first video where you can see what I'm talking about is enucleation of the fibroid. You'll find that this enucleation is very different from what we normally do in a lab. In the lab, we put the myoma screw, pull the fibroid, push the uterus, and in one push, pull, everything is done. But this is a very fine technique in which I call it as a PST technique. That means you slightly push with your bipolar or the forceps, like the way I'm doing, then toggle your scissors, spread the fibers, and toggle your scissors. So you're actually absolutely in the intracapsular plane, and you get the myoma out very, very precisely from the bed where you want to. The suturing can become very difficult. So just I want to put you two videos side by side. Both are exactly the same size, same location. And as you said, I don't only do robotics, I do a lot of laparoscopy as well. So I'm going to show you one robotic and one lap. See for yourself, these are the MRI, anterior wall, large myoma. Both surgeries, both patients have almost same fibroids. That is post-enucleation. Now you just watch the suturing in both the screens. Also watch the stability of the vision. In the robotic screen, you can see it's completely stable. There is no movement of the camera. Plus, you can see the ease of suturing because of the wristed instruments. You don't have to keep rotating your shoulders to get the right parallel needle holder to your wound or to your scar or to your incision. In this, you can just rotate and come to that, and you can get the needle out exactly. And this is happening because you have wristed instruments. And of course, there is also tremor filtration. As I said, in this same patient, we did about four layers of suturing because of the transmural defect. The time in robotic suturing is half what I took in laparoscopy. And I think I'm as skilled in both and been doing it for laparoscopy for more 22 years and robotics for 12 years. So, but still, I have learned to do and suturing faster with robotics even today. Sometimes you can have a very large myoma. And in this large myoma, the challenge sometimes is, this is a large myoma, is that you need to get the myoma out without damaging the endometrium. Of course, always understand where is the cornu, whether you're going to damage the tubes or not. Proceed with the fibroid location exactly, and then go ahead and make an incision. So in this robotic myomectomy, in these particular patients, we make incision with a scissor. As I said, my PST technique, where you spread with the forceps that is in your hand and go absolutely intracapsular, dissect the myoma out slowly, keep increasing the incision as much as possible. Many times in a lap myomectomy, we are worried in making a very large incision because we know we have to also suture it. But here, suturing is no issue. So you make as big incision as you want to get the myoma enucleated properly, nicely, intracapsular, and then go ahead and then suture. So this is the same suturing that we were showing. We'll go to the next one. Again, if you have a large FIGO class 2 myoma, which is completely into the endometrium, pushing on to the endometrium, preserving that endometrium is also very important. So in this particular patient, I can just show you how delicately you can actually peel the endometrium off delicately without using any electrosurgery. And then at the end, you will find that the endometrium is completely intact, which is what was the desire and your desire, and of course, the desire of the reproductive person. And that's where the suturing is then happening. You can have multiple fibroids. In challenge with multiple fibroids is sometimes that it becomes very difficult. This is a very large fibroid, which has a submucous extension, almost 6 centimeters, has a large cervical fibroid and multiple more fibroids. So you can see that's where the submucous fibroid is. That's the large cervical fibroid. So in this particular patient, removing a 6 centimeters hysteroscopically is near impossible. You'll have to do 2 sittings. In this, you can easily remove the cervical fibroid, make a small incision, and then pull the intra-submucous component of the fibroid out. And that's where it is. You can just see I'm getting a help with one of my assistants, and that's the 6 centimeter size fibroid, which is coming out from the same incision and then closing the incision for this patient. Or delocated fibroids can sometimes be also challenging. You can have a uterosacral incision where you will have an incision or an absolute dead-on posterior cervical fibroid. So whoever does myomectomy knows that a dead posterior cervical fibroid may be okay to enucleate, but suturing can be mind-boggling there. And you will not be able to do a good job of 3 or 4 layers. So this is a uterosacral fibroid going on your left screen, and that's a dead cervical fibroid that's going on the right screen, where once we remove, it's the cervix. You need to repair the cervix nicely so that it can hold the next pregnancy. Too large a fibroid, I think I will go to the endometriosis now because limited time. Endometriosis, direct involvement. Fertility subspecialists are all worried, surgeons are all worried. So endometriosis is always a problem of 2. We need to reserve ovarian loss, we are worried, and we are worried about the recurrence. So surgical technique matters. And how does it matter? By doing good diagnosis, when you can see better, surgical technique, and of course with deep infiltrating endometriosis. These are all the pictures that you can see with a robotic camera. You can actually diagnose them much better because you see them much better. And what you could do is surgical excision can be either elective or contraindicated, or you will be required to do an endometrioma. So how do we do, or why do we say that endometriotic surgery is better? Now, this is the same patient. I gave you an example in the beginning of what should be the optimal approach. You can see the ureters quite well. This is the rectum being pulled up. Ureter is identified. You can open the peritoneum and dissect it as well. And that's the right endometrioma, which is a large endometrioma. What I wanted to tell you is the technique that we use for cystectomy in an endometrioma is very different from what I was taught. And I also tend to do it in my laparoscopy, which I'm trying to change from what I'm trying to do. If you see this, we are using a very short burst of monoporal current and getting right at the cyst line and dissecting the cyst of the ovary so that we don't have a ovary which is left behind with petechial hemorrhages. Because if you get that, you ultimately end up using some bipolar there. Here, if you can do a very sharp, and I can see this tremor filtration, so I can do a very precise one short burst of maybe a millimeter of a second with level 3, which is the least level 3 or level 4, least damage, keep my watts and the Irby machine that you have with this also has a stable power, not a stable watt. So the watt can change, but the power remains same. So the damage is less. Sometimes you can also have the focal adenomyosis of outer myometrium, and then you need to excise all this. So precision is also needed. You can also have sometimes coexisting endometrioma, adenomyoma, multiple fibroids together. So in this particular patient, we had almost every bilateral big endometriomas. These are the ports. And then we go ahead, first get the anatomy right, then remove the adenomyoma, and then go from anterior to posterior, keep picking out all the fibroids and bagging them. So these are all the techniques which can use in a complex patients with this kind of situation. Then the problem of deep infiltrating endometriosis. What do you do? This is a ureteric nodule which was there. You have to start from the pelvic brim, dissect the ureter, and then remove that. You can have some deep infiltrating endometriotic cysts in patients like this. You can have left ovaries completely adherent, start from the pelvic brim, get your ureters right, and then go ahead and reduce the uterosacral nodules. I'm really not taking you through so many of videos because small videos you may or may not understand so much right now, but we can take you through these surgeries. And as I said, if you visit us for the meeting, you will have masters teaching you all these very, very well. So we have whether robotic surgery or laparoscopic surgery, which you should do, which is good. In the systematic review and meta-analysis, robotic surgery was not inferior. And I'm sure when we have experienced surgeons with robotic platform and experienced laparoscopic surgeon, we might find better results in robotics. You can also do cerclage. This is one patient who had actually lost three pregnancies. We did an interval cerclage for this patient. Good that she conceived after that, and she also delivered by C-section later. So this is the standard technique of cerclage. Only the tools are different here, which you are trying to use for more precision to be able to do the same technique. So robotic tubal reversal, you can do. Many patients regret having tubal ligation and they come back to you. So doing 6-0, 8-0 suturing with a regular laparoscopy with a tremor at the end of it is not everybody's ball. So you can use the robotic platform to do this kind of tubal ligation very, very well. You can do ovarian transposition, transabdominal oocyte retrieval for aortic ovaries have been transposed, or minimal access approach. It can be easy. You can use robotic platform to do as well. You can do ovarian tissue cryopreservation, where prepubertal girl who can undergo controlled ovarian stimulation. So ovarian tissue harvesting, you first have to harvest the ovarian tissue, do cryopreservation, and then transplant it in the patient's abdomen somewhere later. So robotic surgery has come a long way in one decade that I have been doing. And I say for this, as Mahatma Gandhi would have said, that if you try to do something different, and that was when I started off in 2012, they ignore you, then they laugh at you. I was, and then they fight you, but you win. And today, the fact that so many of you are coming forward to understand what is this technology, how you can integrate into your practice. And as I think most of the audience today and our chairpersons and others are reproductive medicine people, this is a platform for you to do your own surgeries. In fact, way back in 1992, that's some place where we were also starting to dabble in laparoscopy and gynecology in India as well. Dr. Roy Pitkin actually wrote an editorial in the Green Journal and raised 5 points. That is there technical feasibility? Can we have quality assurance? Is there appropriate credentialing for people to do laparoscopy? Is it experimental? And who's going to bear the cost? But 18 years later, he actually changed his editorial, and the same guy again wrote that laparoscopic surgery has established as a scientific base and developed educational methods and become integral part of gynecology. And I believe the same thing is true for robotics as well, because today it is now standard of care in many hospitals. These are the new robots that are on the anvil. This is the Teleflex. This is the Versius of CMR, which you already have here. And of course, you can always look into all the publications and the data that we have shared and discussed in peer-reviewed journals and chapters and books many times. So all this is there for all of you. This was the 3D technology, which is now we are integrating to do robotic myomectomy in complex robotic myomectomy, trying to locate all the fibroids before. It actually deserved the cover page of JMEC journal, which was good for us. This is the 5 modifications that I was talking about, the Jogi article. We also have published our single center experience as well as multi-institutional trend of gynecological robotic surgery in India. You can look up in this. We have also discussed our outcomes of robotic myomectomy compared to laparoscopy beyond the learning curve. So first 4 or 5 years for us also was a learning curve. This is a book. You can find many things discussed about fibroids and robotic surgery in this. Dr. Arni was one of my co-editors in this. So the take-home message today, laparotomy is really no role in a patient who is looking for fertility enhancement. Outcomes comparable to laparoscopy in the hands of highly volume surgeons. But robotics can be enabling technology. Learning curve is small. Helps you achieve the real-world surgical proficiency. So you need not be 12 or 15 years in your practice to give the patient same clinical outcome as you could do it in 3 or 4 years of your practice. Reduces the need to convert to open surgery, and believe me, it is, and evolving as a powerful tool in the hands of reproductive specialists. So I thank you for this opportunity. I hope I am able to talk to some of you to take up robotics, because this is the future. and that will help you do your surgeries much better. Thank you, Komal, and thank you, Niranjan, and thanks everybody, all the chairpersons, the people who are there, who managed to put this thing together. I'll stop my screen share now. Thank you.
Rakhi, unmute.
Yeah, I could not hear. Yes.
Thank you, ma'am. It was lovely talk, and who else could have done justice to it other than you, with giving a bird's eye view of the whole robotics completely, how important it is to have minimal tissue damage, tissue injury, and have maximum benefit out of it. Lovely, ma'am. Thank you.
Thank you, Rakhi.
Dr. Anshumala has joined.
Put a message. She was washed up for a case. I think she's joined and she's left. Okay. You can go ahead.
I think we can move to the next session.
Dr. Ruma, it was a wonderful talk. I'm totally mesmerized looking at those robots, and it was really, really nice. I right now can't go back, and I'm right now too much into IVF, but it was really mesmerizing. Thank you so much. Thank you so much for that amazing talk.
Sheetal, nobody is stopping you from doing IVF, but this is also, man.
It is so lovely and so fascinating. Yeah.
You
so
will fall in love with it, I'm telling you.
Ma'am, it's easier said than done. The learning curve is very, very long.
Yes.
No, I'll teach you very fast, don't worry. I'm
Chalo,
looking
Sita, let's make a plan.
Chalo, Hyderabad.
First step is come to Hyderabad. See that 2 days in meeting.
Listening to her talk, I also feel like just changing my field and then entering into it, and it would be really.
Please come.
Good.
And I don't want you to change the field. My talk today was focusing on all you who do reproductive work to actually kind of do your own surgeries. I don't know how Jyoti will feel about what I'm trying to say. What, Jyoti?
Madam, what from my view expression is so much difficulty. We have now excelled the field of fertility. Changing and going back from scratch. And of course, you made it very easy.
Yes.
I know when we do laparoscopy, it is.
I believe me, laparoscopy is difficult. But I believe, see, all of you have one myoma getting into the submucous cavity,
But when I go to that robotic area, I feel I'm like not a normal human being. Somewhere I'm in some other this one space itself.
Yeah, in some space.
That whole console
kind of
and everything.
I do see when we go to that robotic space.
Ma'am, whatever said and done, I'm at least going to come and try my hand. At least if I like it, I can pursue it. I am coming, ma'am.
So we are actually starting some very, very simple training with the European Society. We are giving small trainings. And the first level of training is only for people like you who have never done robotics. Just do and see the psychomotor, what is happening. Is it for you or not?
Yeah.
And then from there, I'll take you.
Yeah, in life, I think we should have some space to learn new things as well.
Yes.
Brain keeps
We need to learn new things, and I think that thing what Madam said, to come and try, it is very important. We all should. Yes.
Please do. I look forward to it. And I hope you guys will go and register right now today. There is very little registration fee. It's only 6,000 rupees.
Yes, madam. After my elections.
On our, I'll put it in the group. Yeah, and that group I'll just put that in. Good.
Yeah. So thank you so much, ma'am. And now we go to the next session. That is the talk on endometrial receptivity. And for that, we have our chairpersons. The first chairperson is Dr. Selva Priya, the super dynamic Selva Priya. She's a very dear friend of mine. She is an obstetrician, gynecologist, fertility specialist, fetal medicine specialist. She's the director of Spring Fertility Fetocare Fetogene at Nagarcoil, Tamil Nadu. She's the clinical director of the Department of Reproductive and Fetal Medicine. Over to you, Selva Priya. And the next chairperson, Ritu, you want to take it?
Yes. The next chairperson is Dr. Tripti Bansal, who's the Director and Consultant Gynecologist at Sumitra Eye Care and Maternity Center at Lucknow. She's presently the Head of Department of OBGYN at Sumitra ECMC Lucknow. And she is also, her major achievements involve formerly at Elizabeth G. Anderson Hospital, London, UK, and Women Child Hospital, Chennai. She has chaired and co-chaired and moderated many sessions and webinars in different conferences at national and state level. Welcome, madam, for this webinar. And
Thank
I
you.
would
Thank
request
you.
you to take this forward.
Big thank you, AGOG and Dr. Komal Chauhan for including me for this wonderful academic feast. And we are very blessed and honored to have with us Dr. Kamini Rao ma'am and Dr. Sunita Tendulkar ma'am. Now I would like to invite Dr. Jyoti Budhi. She is a medical director of 49 Fertility Center. She has 7 centers across the Telangana and Andhra Pradesh. She is a SR Joint Secretary. She she is a she has done her MS from UK, diploma from diploma in reproductive medicine from Germany, conducting IVF training program with Foxy and IMA for 7 years, and she has trained more than 200 gynecologists. She is an IFS certified embryologist, contributed many chapters in several books, invited as a guest lecturer, and presented many papers in national and international conferences. Under her leadership, Economic Times awarded 49 as the best integrated IVF chain of South 2022. Welcome, Dr. Jyoti Budhi. Over to you.
Yeah, Dr. Selva, you can add. I think you know Jyoti very well, so I want your word.
Thank you. So, as another chairperson of this session, I would like to say hi to everyone and a big hi to all my girls here, Komal, Ritu, Sheetal, and Jyoti as well. And I just the discussions about the previous session because nowadays we've just put ourselves into small compartments. I'm this, I'm that, I'm that. But you know, a senior person like Madam, she spoke about robotics and she's encouraging people like us to come and try with us. So I think basically as obstetrician and gynecologists, we should be, queen of the whole field. And without any delay, first let me say a warm welcome, extend a warm welcome to my dear friend Jyoti. Jyoti, you're going to talk about thin endometrium and so looking forward to and we're going to have a very good discussion. You're having all these girls, they're not going to leave you after this.
Yeah. Thank you so much. So meanwhile, until I share my screen, I would take this opportunity to thank AGOG team and also Dr. Niranjan Chauhan and Komal Madam for inviting me here. And of course, my thanks will not end if I don't thank my dear friends, Sheetal, Selva, and also Ritu. So, and of course, I had this opportunity. Yeah, can you see my screen?
Not yet, ma'am.
Not
yet.
Not yet.
Yeah, now?
Yes.
Yeah, perfect. Yeah.
Make it full screen.
Yeah,
now it's full screen.
Yeah, so it's lovely, wonderful afternoon today, seeing so much about a robotic. You know, it really at 1 minute I forgot I'm a fertility expert. Thank you, Dr. Ruma, for giving such a beautiful lecture and training us about understanding about robotics. So from robotics, now we'll come to the real space of fertility. So I'm going to talk about endometrial receptivity, which of course a very, very enigma and a challenging topic when it comes to endometrial receptivity. Let us hear from the words of Aristotle long time ago. He said about the endometrial receptivity in his own words that the womb is a field of generation, and if this field is corrupt, it is so vain to expect any fruits whatever it is sown well to grow in this womb. So when we say about endometrium, it's such a place where it nurtures the endometrium and takes it forward. So the health, the ecosystem of the endometrium plays a pivotal role in implantation. So it's so very important about the endometrial receptivity. So today in my lecture, the whole framework is based on what is endometrial receptivity. And most importantly, to understand a little bit of the window of implantation, very important. And are there any factors where this endometrial receptivity gets affected? And of course, failed implantation for 3 or 4 times repeatedly, when there is recurrent implantation failure, they're so tired, they're so drained. And when it comes to assessing this endometrium, what markers we have, which is so expensive, is it really worth doing all these tests for these women who have already drained with both the financial aspect and emotional aspect? So what role as an fertility experts we have? And then, of course, end of the day, all things tailors to the treatment part. Whatever we know, whatever we find out, whatever research we do we have any modalities to treat a lady with a recurrent implantation failure, especially finding out there is a problem in the endometrium? So let's get started and see what is it. So when it comes to definition of endometrial receptivity, it's basically defined as a state where this endometrium, which allows the blastocyst to attach, not only to attach, it allows it to penetrate, and also it causes lots of changes where yeah. So about what is implantation? Implantation, important things happen in implantation. One positive things which happens is there is acquisition of lot of addition factors. And the second negative things what happens is all the inhibition to the embryo should be lost when there is implantation going to happen. Yeah. So one word about window of implantation. We understand about window of implantation. As we know, every house has a window. Even the endometrium has a window. The window is not open all the days. It is in a specific period only this window is open. So when a conception needs to happen, a blastocyst should be implanted in the endometrium in the specific window period. Usually it occurs around 20 to 20 days, 24th day of the menstrual cycle. And this coordinates with the 5th day of progesterone exposure, and of course, the 7th day of LH surge. How many days does it last? Only 4 to 5 days. So we as fertility experts, in all our FET, all our embryo transfer cycle, we try to find which is the best implantation window. We have different modalities to find the window of implantation. It lasts for 4 to 5 days itself. So this is a very beautiful slide. I fell in love with this slide. In endometrium, there is something called as receptivity and selectivity. What is receptivity? Receptivity is how receptive the endometrium is. If you see in women, it is little narrowed down in normal women. If you see in cattle, dogs, cats, the receptivity is very high. It's not narrowed down. So many embryos implant. That's the reason they give birth to 5, 6 multiple pregnancies. So the receptivity is, prolonged in cattle. But when it comes to humans, the receptivity is little narrowed down. And if you see in women where there is little better receptivity, most of the aneuploid embryos also implant. That is the reason this becomes receptive. It takes in the aneuploid embryo, but after some days, she will have miscarriages. So women who are having more miscarriages, thing called as selectivity. As in some women, the selectivity of endometrium is very specific. It is very choosy. It selects only a few embryos. So these are the women who have delay in pregnancy, in conception. So end of the day, there should be a balance between receptivity and selectivity. As the woman grows older, they became very selective. That's the reason most of the aneuploid embryos doesn't implant. And then it is known that human endometrium itself acts as a sensor for the embryo quality, so that aneuploid embryos don't stick and we don't have lots of miscarriages. So of course, when it comes to role of estrogen and progesterone, one day is not enough to talk about it. So we'll not go into depth of it. It's very important. It brings a lot of changes, especially in the microenvironment. There should be a coordination between the endometrium and the progesterone for a beautiful endometrium. Now, having said that, now next is, what are the factors which affects the endometrial receptivity? Of course, we all know age is one single most determining factor, not only for euploid, it also affects for the endometrial receptivity. As women age, her endometrium becomes more selective, more choosy. And then what are the other factors where we have issues with endometrial receptivity? If you see morphological factors like a space occupying lesion like a polyp, it not only stops the sperm, it also messes with the endometrium. Lot of contraction it sets, and then it also causes the internal environment. There is a problem with the whole endometrium itself. And then fluid in the endometrium, which signifies some kind of infection is there. All these are the factors where when we do a scan and we see a fluid in the endometrium, we know there is some issue with this woman for the receptivity. Also adenomyosis. So this adenomyosis is challenge. I think all my fertility experts echo with me. When you see an adenomyotic uterus, it's so challenging to get a endometrium for them. And of course, endometriosis, there are a lot of studies which says the whole ecosystem is, there's a lot of issues in the ecosystem, the microenvironment when it comes to endometriosis. About fibroids, the closer it is to the subendomyometrial junction, the more is the problem with the fibroid. The farther it is, there are a lot of studies says it doesn't harm much. Of course, hydrosalpinx, we know when there is a woman with hydrosalpinx, whatever the tube is, if it's a descending infection, what happens? The tube is damaged, then it goes to the endometrium, and the pH of the fluid in the tubes, when it trickles down, definitely there is a problem in the implantation. Of course, calcification or any infection which affects the endometrium, definitely it becomes a very challenge in getting a good endometrial receptivity. And of course, there are a lot of studies about PCOS even. That's the reason even this women, even though we get a very lot of embryos for in PCOS women, but end of the day implantation, there is an issue, challenge with PCOS women as well. And then whenever we do stimulation, when you have to do a fresh transfer, if you get more, they say it's good because of our ANTAC protocol with agonist trigger. But then to do a fresh transfer, it's always a challenge because of the advancement of the endometrium, what we see in when we go with the overstimulation. If you see, there should be a balance. What is a utopic endometrium? What is that fertile endometrium which can implant a euploid embryo? Is there should be a balance between all the markers what we will be going through in next. And about PCOS, just one word, what it exactly does it not only, there is some kind of subfertility with this woman. There is dysregulation in the expression of all the markers here, especially a woman with increased testosterone. It directly hampers the expression of HOXA pathway. And then because of this, the modulation of estrogen, there is a problem and decrease in the implantation rates. Now we know what are the challenges. We have already identified this women have some issue with the endometrial receptivity. So what do we have? What do we do with her next? Do we leave her like that 3-4 times she has failed to implant? Is there any test which gives any value with the evidence? Because end of the day, we all know, 3 to 4 implantation failure, these women are emotionally disturbed. So they're just hanging on to us, do something. I just want to become pregnant now before going to surrogacy, because it's so tough now because of the new law. We have to try best for our women. What is that we can do for her? So if you see the evidence about how to evaluate the endometrial receptivity, let's speak about it. Past, there were many. Now present, there are more. So if you see the present and the future, to evaluate an endometrium, there is a very non-invasive test, what we are really fertility expert. Without that, we can't exist. They are the scans, what we regularly do. And of course, there are some invasive tests, which I'll be talking in the coming slides. Past, of course, history, we need to remember also sometime. Noyes in 1950, 80 years before, he found out there is something called as histological grading of endometrium. Initially, because of recurrent pregnancy loss, is there a luteal phase defect? This was the criteria they used to use. But then later they thought, let us use this criteria for endometrial receptivity. But then we all know that it doesn't have any significance. It's an absolute method now. What is in the present? The present is most important is our Applebaum's uterine scoring, which everybody does. So if we have to see a woman with, especially with recurrent pregnancy failure, we need to enforce more on our ultrasound, which is, very cost effective. We usually do the endometrial. This Applebaum score is very simple. It has 7 parameters. Ideally, we do thickness. Everybody does thickness. Anything above 7 mm or 8 mm is best with the triple line, what we see the layering as well. So we can go one more step ahead and even see the endomyometrial contractions, if there is any contraction in 2 minutes. Of course, 2 minutes is very precious, but it's worth for these women. We need to see if there is any contractions, and also echogenicity. And uterine artery Doppler flow is very, very important. And then even the endomyometrial flow also plays a significant role. After doing an Applebaum score very thoroughly for these women, the score says, anything more than that, 20 chances of implantation when it comes to a euploid blast with a good endometrium, chances are more. And when it's less than 13, pregnancy score is 0. So it's worth doing this test. Then, having said that, about endometrial thickness, everybody knows about endometrial thickness. All the studies says best chance of pregnancy is when endometrium is between 7 to 14 mm, highest clinical pregnancy rates. And then what else? Is there a value of endometrial volume? A lot of studies, but what is the conclusion of all the studies? They say endometrium volume in all the studies, IUI, it gives more specificity if the volume is more than 2 ml. For IVF, 3.2 is the volume where the sensitivity is 80%. And then about Doppler, there is a lot of conflicting evidence. I just want to share my personal opinion about the Dopplers. We had one new consultant, I had to face them. So she was so much into Doppler studies. What happened was the day of embryo transfer, it's such a holy day for us. We want to be very positive and very peaceful on that day. She wanted to do a Doppler study and decide on that day whether she has to transfer or not. Imagine in certain situation, the patient is ready, she has come all the way for a transfer, and this doctor does the Doppler, and if the score is not good and should I transfer or not, it becomes such a negative zone. So I had to go through a lot of literature and show her that on the day of embryo transfer, doing Doppler doesn't increase the pregnancy rates at all. So on the whole, if you say about if you see accuracy regarding the Doppler, whether it improves the clinical pregnancy, it is insufficient data and we need to do more research on this. Then about endometrial wave pattern. A lot of studies are there, but what is the conclusion? All the study echoes the same. The wave should be of low frequency. And then it should be the cervicofundal contraction should decrease after an embryo transfer. And this is directly associated with the good clinical pregnancy rates. And then when it comes to markers, there are a lot of studies. I don't want to go in depth of this, but then all markers, what the study says is there is lack of accuracy and predictive value. Ideally, end of the day, endometrium markers, if it is in phase with the endometrium, conception chances are high. And then about NK cells, we used to see a lot of prescription with many NK cells, but then I've stopped doing that personally because whatever you do, how do you treat that? You just know there is NK cell increase. I personally don't encourage, but then for completion, all studies says that there is increased expression of CD16 and CD56, which if there is increase, and then this can lead to a recurrent pregnancy loss. course, there are so many things happening about the pinopoids, the morphological evaluation. What studies says is there is some validation about the pinopoids, and then end of the day, the score they have, pinopoid index score, more than 85, they say there is increase in pregnancy rates. If you ask me, I have never done this test, but there is a lot of research happening in this space. And now comes to the age of omics, everywhere in all the conference, omics with AI is the talk of the day now. So we have this is our available, arena now. What are the omics? The transcriptomics, proteomics, metabolomics, so many things are there. So if you have to say just one, how does it work basically? What they do is we do an endometrial cell we take, and then the RNA extraction is done, and a lot of amplification is done and hybridization technique, and then they give us, they integrate with their operation software, and then they give us when to do what. So at present, commercially available, everybody knows about ERA. ERA, lot of debates, lot of conflicting evidence we have about ERA. It is an array where 238 genes have been studied, and then they give us a kind of report. What they do is, basically, it's an invasive test. If you ask me, I do only when there is 3 implantation failure. That one where euploid, blast I put, still there is a failure, then I go for ERA. I'm not I used to do before, but then slowly seeing so many papers, only this is the condition when I do ERA. And also if I have to go for a single embryo transfer, so that is the condition when I go with ERA. So I don't have to go in depth. The end of the day, the result what we get is it a receptive or a non-receptive endometrium? If it is receptive, go ahead and transfer the embryo. If it is not receptive, what do you do? Again, you need to validate doing an ERA and then find out the window of implantation. So next is we come to all the new, what is this, EMA, ELICE, and then the TRIO. So these are the future for us, integrating this with artificial intelligence. Oh, just to complete, what does this EMA stands for? It endometrial microbiome metagenomic analysis. Basically, what it tells is, though it sounds something very great, but if you read about it, it's nothing but the uterine microbial environment, the lactobacillus, what is present and how it can increase the pregnancy rates. So one of the studies says that if the woman has a receptive endometrium, in this receptive endometrium, if the lactobacillus dominant vaginal environment, success rate is better for these women. And then, of course, what about the chronic infection, ELICE test? We also know if there is an infection sitting there in the endometrium, chances of receptivity decreases. So these are some tests where we can find out what is there a chronic infection sitting in the endometrium, and then going ahead and treating this woman. So there is a combination of all these tests. It's called as an endome trio. End of the day, having said all this, so patients are our best teachers. Many times we learn from our patients. We have done all these tests. We have found some real serious problem. She has a problem with endometrium. We tell her, you can never conceive. This is such a false statement we say. So women who have recurrently failed, we have in our, I think all of you agree with me, 4 times failed. Some after given some time, tender love care, she naturally conceives. So said and done, body is an auto healer. Every time it heals. So all said and done, little amount of tender love care is also important for this woman who is having recurrent pregnancy loss. Now we know about endometrial receptivity. Is there something how we can treat it? No, end of the day, treatment is the most important. Just diagnosing and leaving it there doesn't serve the purpose. What do we do? So in any field, when we don't know the problem, there is no solution. So most of the time, all these studies, we are not having a specific, we don't know the specific problem. So when there is no specific problem, even treatment is not specified. What do we do? Whatever said and done, we have to try many things. How do we try? First is to increase the vascularity. We know we have all the armamentarium to increase the vascularity. Next, when we do, if she needs a fresh transfer, going and reducing the gonadotrophic dose. Third is the immunomodulation. Fourth is endometrial scratching and PRP. Just, I think in 2-3 minutes, I will complete the treatment because it's very important part of the, end of the session. So increasing endometrial vascularity, we all, whenever there is recurrent implantation failure, I think we all try this. Whatever evidence says, we know Cochrane says it doesn't add value. But what is harm in giving Ecosprin? It's not so expensive. So as well, it increases the, we know it increases the vascularity. So I do give aspirin, I do give sildenafil, and though I know that it doesn't benefit, but still I think this goes whenever a woman comes with recurrent implantation failure. When you say about controlled ovarian stimulation, we all know if when we get more oocytes, endometrium definitely is advanced. So try better to avoid fresh transfer for these women. If we have to go with fresh transfer, we need to start with a lower dose of gonadotrophins. Next is about immune system. NK cells, intralipid, of course, evidence are conflicting. And now some of the papers, what I see is support of endometrial scratch. Then again, I got to read this paper in the 2017, which contradicts about endometrial scratch. Again, it depends upon we need to individualize. What is there in just if she has failed 3 times, call her the previous cycle, do a scratch. You don't know. If she's lucky, this may work for her. And then PRP, of course, now all the evidence is saying that this was a study which was done with 625 women, increase in clinical pregnancy rates and also endometrial thickness. Doing PRP in a bald endometrium is something, if endometrium is more than 8 mm, I think maybe we can try this. But if endometrium is repeatedly thin, we are not getting the optimum endometriums, 5.5, 6. For those patients, what I do is I do PRP with the, subendomyometrial junction. I put PRP through hysteroscopy using the ovum pickup needle. This is what we do, and we have got good results with that. And this was a beautiful study which says about endometrial compaction. It's a very easy test. It's not expensive at all. Why don't we use this in our practice? We all know once we start progesterone, there is little decrease in the thickness of the progesterone. So what is this study says? It needs only an ultrasound on the day of HCG and an ultrasound before ET. You need to calculate the difference. If the difference is more than 15%, the endometrial shrinks, they say it's a good prognosis. At least there is some compaction happening in this endometrium. Advantage is, of course, it's cheap, non-invasive. You don't have to worry much. But for fresh cycles, of course, doesn't have any value. Then comes to GCSF. I don't want to get into debate. 3 times failed, I do give GCSF because it doesn't cause any harm. But if you see studies, it has conflicting evidence. Estrogen therapy, of course, estrogen is in all our FET cycles, we usually give estrogen, which mimics the natural protocol. But this was one study where they say high dose of estrogen, 18 mg per day estrogen. I have never given. I usually give 12 mg. That's with, not for everybody. But this study has shown that 18 mg giving for a period of, for the FET cycles have seen endometrium thickness improving. But then when you give so high dose, you need to work on her. You have to see if there is any contraindication or she leads in any other problems associated with high dose of estrogen like DVT, all that. We need to be very careful. So I can't put this study quote and tell people to practice. But for me, 12 mg is what I keep as a cutoff. HCG injection, I too have tried, and there are some studies when you don't get the endometrium at all, she has failed. Try giving 150 HCG, every day in the FET cycles, and it has shown some kind of success. GNR analogs, since last year I'm using as a luteal phase support. We give 0.1 triptolin on day 7th of the FET. And if you see studies again conflicting, but something, for some people something works. So I do use that. Hysteroscopy, when you say all studies doesn't support hysteroscopy to be done, but then at least, in our Indian women, when we don't do 3D scans and we don't know what is happening, 4 times she has failed, I do put a scope and see if there is anything which I'm missing in my practice. So then, of course, Cochrane about, glucocorticoids, some people say, but the Cochrane doesn't support this. So end of the day, what is the conclusion? So some small changes if we can do, if you want to go for a fresh transfer, reduce the gonadotropin dose, PRP showing some evidence, and then checking the endometrial compaction I've started doing in my practice. And when nothing works, different method like vitamin E, sildenafil, whatever is cost effective can be tried. Again, important is to talk to the couple. So many times it so happens when they have failed, sitting and talking to them. And recently I heard Dr. Mahapatra sir's lecture. He gives a prescription. He says, change the doctor. 4 times she has failed with you. Something can happen with another doctor or whatever, changing the star also, sometimes they say. And of course, we should not forget about the tender love care we have to, that also, involving all these, we should go ahead with this women. So end of the day, thank you for giving me this opportunity. Endometrium is like I call it a soil. It nurtures, it has to nurture the seed. So having said and done, there is a lot of things we need to learn about endometrial receptivity. It's a challenge and a lot of advances are happening in this field. Thank you so much.
Selva, you want to say something?
Nicely explained, Dr. Jyoti. Nicely explained, Dr. Jyoti. The take-home message is big love care, I think, and increase happy hormone. I think if we'll increase the happy hormone, then it will be, it works. Sometimes it works.
Yeah.
So, Jyoti, you also started by talking about the endometrium receptivity of cats and, our pets and everything. That's what most of our patients always ask, why is it so difficult? You're showing us a good embryo. You're saying everything is favorable. You're saying my endometrium should come up to 8 mm and there should be good Doppler, because nowadays we are telling everything to the patient before we do the procedure. So when we do, like even now when I did, I'm telling her everything. This is your embryo. See, it's good. This is your endometrium. See, it's good. And then it still doesn't happen, So always, how much ever we do the checklist, it's very devastating when everything is right in the checklist and still we don't get the required implantation. So I think you've done total justice. You've spoken about everything, and you also spoke about using GCF, everything inside for improving the endometrial receptivity. And I also want everybody else to share their experience about having everything perfect in the checklist and still not getting it. That is the worst part.
End of the day, so many times it do happen, they fail 4 times, and given time they naturally conceive and come. We don't know this how it works in fertility. So many times surprise. So I always encourage them to try naturally.
That's nice.
That's very important.
So is there anybody else? Do we have questions there in the inbox?
I think she spoke so well, and everything was so clear.
Everything is agreeable. Whatever she said, she didn't say.
Just one point, what I felt is, I think, Jyoti, that you spoke about ERA, but now I think that everybody
is not.
ERA is out of ERA. So that is something that
ERA is out of ERA, and ERA is it is very difficult. From which part of uterus you are taking the biopsy. There is a different readings with ERA, with lateral wall or right, left, or up in the fundus. If you'll take, then there are different readings will come, and then it is very difficult us to explain the patient also.
Yeah.
May I ask you one thing? Just one suggestion or maybe one comment from your side. See, nowadays we know some things will work and some may not work at all. What is your opinion about antioxidants?
Jyoti, you're taking it, no? Ashish Kal question. Antioxidants.
Yeah, antioxidants.
Better something than nothing.
Dr. Jyoti is asking about.
We can keep that as the tagline for antioxidants.
Yeah, antioxidants is, if so many times I have presented topics about antioxidants, and I have dive deeply, and I was in a debate pro for antioxidants. So when you say you exactly don't know what is working for some micro environment problem, any mineral defects, I do give, not for longer time, maybe couple of months.
Mhm.
And especially
That's
our
something
Indian
that's better
women,
than
when the
Better something
nourishment
than
also is a
nothing.
problem.
Especially when you have a checklist where everything is, good, and you still don't get it. You need to do something. You have to believe in something.
Yeah.
Yeah.
So I think we'll move to the next session. Thank you, Dr. Jyoti, for a very nice talk on endometrial receptivity. I know it was a very difficult talk. So our next session is a panel discussion on RPL, that is recurrent pregnancy loss. And we are going to try the clinical and the embryological perspectives. And for that, we have our moderators, that is Dr. Ashwini Kaye. Dr. Ashwini Kaye, what do I say about you? She's a very, very dear friend of mine, and she's the chief embryologist at Asha Kiran Hospital and Asha IVF Center, Pune, Hyderabad, and Arunachal Pradesh. She is the secretary at the Pune OBGYN Society from 2020 to 2021, and the treasurer at Maharashtra Chapter ISAR from 2018 to 2020. The co-moderator is Dr. Ashish Kaye. Ritu, you want to take it?
Sheeta's been giving me personalities that really don't need any introduction since the beginning of the webinar. Ashish doesn't need any kind of introduction. So Ashish, welcome. Everyone knows you. You are well known, well loved, well appreciated about your knowledge.
Thank
I
you.
would request you and Ashwini to take this forward.
The dynamic duo is going to do the moderation for this next panel. So please go ahead.
Can we share the screen? It's been allowed.
Yeah. Thank you so much, Komal madam. I think this is the first kind of a panel that both of us are going to moderate. I mean, first time we would be sharing screen like this. Thank you.
You both
I
are
like
looking
how
very
you
nice.
both are
Yes,
sitting
that's why I'm
together.
so excited.
I was looking out for Ashwini, then I realized you both are sitting
Komal
together.
madam, this is the first time. I think one family and another also, there is a panelist.
Yes, Nishad and Amog.
Nishad
Yes.
and Amog.
Yeah.
So two Kales, two Chimotes, and one Rohan. So it's
Oh my God, Sheetal, we didn't realize.
Yeah,
it's
Yes.
a good one.
it's very great.
Looking forward. Yeah.
You can see us in the same screen also.
Yes.
Oh,
I
wow,
saw that.
that's
I
lovely,
saw
that's
that.
lovely.
Confused whether to log in from
Hi,
two
Raju.
systems or the same system.
Yeah. Can you allow to share the screen? It is yes. Yeah.
Yeah. So we'd like to invite our panelist, Dr. Rohan Palshetkar, who's the treasurer of AMOGS now and a very active member of MSR and SR. Dr. Amol Lunkad, who is from Pune, director of Indira Fertility. Dr. Surakshit Bhatina, is he there? I cannot see him.
Yeah, Surakshit's here.
Okay. Dr. Vipin Chandra, Dr. Nishad Chimote, embryologist from Nagpur, and Dr. Amok Chimote, the very well-known laparoscopic surgeon from Nagpur as well. I welcome you all to this very interesting panel on RPL. So I would like to any of the panelists basically to tell us about the basic definition of RPL for all our audience. Maybe Rohan, we can start with you. How would you to define RPL for any
Yeah,
of
so I think this has always been a little bit of a controversy because generally we've been talking about 3 consecutive losses as per the definition. But I think in current practice, when we look at it, we're never looking at waiting for more than 2 pregnancy losses. We're not really waiting for the third one to occur before we're actually going for any of the investigations. So even fertility, sterility, as you've mentioned, ASRM has published all the way back in 2012 that if you have already 2 cases of recurrent pregnancy losses, we should start investigate them and not really not really wait for the third one to actually occur.
True. And I think
So if I may.
Ashwini, I think Dr. Vipin has also joined. I think you forgot to introduce him.
No, I called him.
Okay, yeah.
Ashwini, if I may come in.
Yes.
Yeah, so there's another definition which says that it doesn't need to be a consecutive loss. So any loss with one pregnancy, then again a loss can also be defined as a recurrent pregnancy loss.
So, Amok, do you think when you're talking about the RPL, the age of the patient that matters? Because nowadays if she is a 40 years or maybe a 39 years and coming down to you with one miscarriage, do you think that is one of the things we should take it seriously and investigate her, thinking that she may have a repeated pregnancy loss later on?
Yes, definitely. So
That's
age is one of the most important factor. So if you are having a patient aged 40 and above, even one loss warrants a complete investigation for RPL.
Okay.
I was also adding, there was a study in 2014. They said 37 years should be a cutoff. For 37, lesser than 37 years, if in case the patient is non-IVF pregnancy, then it's more than 3. And for more than 37 years, it has to be around less than 2. So that's how they usually classify.
Like if it is she's of 39, so you think that's we will definitely going to investigate her more in order to know the facts that
It is
is
lesser than 2. Yes, sir. Yes, sir.
it increases the proportionate risk of having her abortions more later on.
Right. Yeah.
See, one more thing I wanted to add is
Yes.
after the first pregnancy loss, having a next loss, the chances are around 14%. Literature varies between 12 to 15%. But after the second loss, the chance of having a next loss increases to around 22%. So that is why it is better start investigating at least after the second loss.
So Amol, do you think that understanding the possible reasons for miscarriages, coming to the extensive diagnostic workup, and then a successful treatment may have a half-hearted pregnancy? You seen the cardiac activity has been documented, and again, if that particular pregnancy has a loss, so it's a vicious cycle to run around. So if you are thinking in that particular fashion, so what is your modality of the treatment, starting from the history? What do you like to have as a history for an investigation for RPL?
So basically, when we evaluate patients of RPL, history has a very important role, right from the history of addictions to various, you can say, addictive agents like even caffeine or smoking, tobacco, alcohol. All of them would have an impact. Other than the also history of consumption of various drugs can be there, or history of using of eye pills or contraceptions, contraceptive medicines which have been used without any proper prescription. All this is going to add up to their, you can say,
my question to Dr.
risk factors too.
Yeah.
So other than in history, other than the obstetric history or the gynecological history, what were the losses, how were the losses, in which trimester were the losses, whether the fetal heart was documented or not. That is the usual history which we take. Other than that, the history of any addictions and contraception becomes important.
Yes.
So
my question to Dr. Vipin, if there is a gray zone between she's given the history of having the urine pregnancy test positive, and suppose after the say few days over she's started bleeding, so do you consider that particular history will play some role in RPL cases?
Definitely, Ashish, because as Amol has said, history-wise, we need to understand whether these are the early losses or the mid trimester or the late trimester, late and third trimester case. Also, RPL can happen. So we had then this kind of history will help us in zeroing down which investigation to be offered, what are the important causes may be there, because these the time-wise the problems and the causes are varies. So if it is an early pregnancy where as you suggested, she has a biochemical pregnancy but then had a bleeding, can be a lot of because of many reasons. Genetic is one of the reason. Progesterone insufficiency, luteal phase insufficiency can be a problem. Immunological can also be another problem. So we have to stage wise we can identify and then put up investigations accordingly.
Yeah, so I'll just ask Nishad. See, we know the RIF now, recurrent implantation failure, and RPL. Yeah. Do you wish to say about what is the RIF and what is the RPL in order to know for the delegates who is attending?
You were talking about recurrent pregnancy loss and implantation failure, right?
Yeah.
Yeah. So obviously the implantation failure is where the implantation is not happening in the first place. So that is what your RIF is. And pregnancy loss can happen post-implantation also. These are the two basic differences that we talk about. So RIF has different reasons. It is not only due to age, but it can be due to the quality of gametes. Pretty much the factors in both are almost the same, you can say. That it's the age of the patient, because the oocyte is very aged, then you'll have a problem in the blastocyst, quality of blastocyst and the formation of blastocyst. That will be one thing. Second is also we have to consider the sperm criteria also. So these are the things that really make a difference in both the scenarios here.
Do you think adding anything in the embryology lab would reduce maybe your RIF or RPL? RPL, there would be a lesser role, but regarding RIF, do you think anything from the embryological perspective?
See, definitely there are. See, we go first is the diagnostic part. We should, in patients where RIF or RPL is there, we have to make sure that DFI is done in the male, because that is one of the most important characteristics, that your DFI, that the DNA fragmentation index, is very different. It is very high, then the blastocyst quality won't be that good. And because of that, even the you have to understand that even if the morphometrically that is blastocyst looks good, yet it doesn't mean that it is genetically normal. So aneuploidy is another factor with DFI. So that you can do. With medicines and antioxidants, well, yes, you can give a pre-treatment to such patients, but that is again, that depends, because there is no concrete study that it really makes a difference. So pre-treatments, yes, it is always benefited, but you can't say about that. And aneuploidy testing is something which you can actually do in such patients. So mostly you cannot give anything. Yes, you can do IVF ICSI in such patients.
And again, start seeing that where we went wrong, whether it was an implantation failure or a pregnancy.
Yeah.
And maybe give more, right? So coming to our first case, this is, yeah.
Yeah. So I just wanted to, first of all, we just have to make sure that the blastocyst is formed, because if that is not the scenario, D3 transfer is not going to help you, especially in such patients.
No, in fact, at time it happens that if the patient is a day 5 failure and maybe you try doing a day 3 transfer and putting in more number of embryos, it might just help at times.
Yeah, I mean, that is a debate for another. I can agree with you here.
So we move on to our first case, where she's a 28-year-old patient with irregular menses. Her BMI is 30, the AFC is 14, and the USG shows a polycystic ovarian morphology. This is her third pregnancy now, and she's come with 2 abortions. One was at 5 weeks with irregular gestational sac and a retrogestational sac bleeding. The second one was at 6 weeks where the fetal pole was irregular and with PV bleeding again. So now this is a third pregnancy with 5 weeks, and we can see a fetal pole. So I would like to know from any one of you that how would you start investigating this case, and is there something that you can add up in this patient that maybe this will not land up in a pregnancy loss? Vipin sir?
Yeah, definitely. Again, as I said, these are all this patient has characteristically showing all the abortions were of early trimester. So we have to rule out the genetic part. We have to rule out the immunological part. We have to rule out the thrombophilias. Definitely, since early trimester is there, so anatomical causes and other causes may not be the possible, but still we should rule out them by doing hysteroscopy and so before proceeding. So
Okay.
I'll suggest karyotype for this patient to get it done for the couple if possible. Otherwise, since already pregnancy is going on, so let's wait for another week and see. It's a 5 week only, so let's hope and whether the patient can have come up with enough fetal heart rate. So wait for another week, put on some immunomodulator and dydrogesterones, which also helps in providing immunomodulation, and lonopin and aspirin, so that and after a week we can see whether the heart rate can come up. If not, if it ends up in abortion, then we can fully investigate this patient.
So Dr. Amog, if you are seeing all the case of this particular patient, all of this sonographic shows the evidence of the fetal pole, but unfortunately the fetal cardiac activity has not been documented. Do you think that is some of the clue that will give it to us something is going
Yeah.
wrong?
So in previous 2 abortions, it did not go beyond 6 weeks, and it was a early first trimester loss. So it suggests that there has to be some either a genetic cause or a immunological cause to it. And since there is no fetal cardiac activity, so you have to rule out thromboembolic disorders in such patients. And on ultrasonography, before transfer also, you should also do a cardiac uterine Doppler indiasis,
No,
and
she's
microvascular Doppler.
spontaneously. So she's coming on the 5th week now. So
Yeah.
considering that particular thing is like going back to that particular thing is very important.
Right. So for this particular patient, on ultrasound, we have to check for the previous 2 gestational sacs were irregular. So we
Yes.
need to check the regularity of the sac. That is one of the most important characteristics that will tell us whether this particular fetus will go beyond 6 weeks, develop a cardiac activity, and maybe continue the pregnancy. So for this patient, maybe you can start her on maybe ecosprin or low molecular weight heparin preemptively for this patient. And so if the cardiac, the fetal pole is seen, sac is regular, continue with all the luteal phase support that have been started.
Attention here, Amog, whether when we are doing something like a APLA test, do you do it prior to the pregnancy or during the
Prior
pregnancy?
to the pregnancy.
It is during the pregnancy. What indicators?
Prior to the pregnancy. Now it won't. Now there's no use of an APLA test.
So I wish to draw attention to some of the PCOM pattern. So I'll ask Dr. Rohan. So this PCOM, whether it is one of the cause that you think like this particular thing will happen?
So one thing, yes, with PCOM patients, I'm more worried about the oocyte quality also, which we would be concerned about. Number one. Number two, her BMI is also on the higher side.
True.
We want to investigate whether there is any history of diabetes or anything, especially in these patients, especially with a higher BMI. So in this situation, I would want to do her fasting blood sugar, her postprandial blood sugar, and even a glycosylated hemoglobin to see whether that could have been possibly missed out in this patient.
Yeah.
Another thing is that now that she's pregnant, obviously we don't have a choice. Even obesity, there have been studies recently that obesity can increase the chances of a recurrent pregnancy loss as well. There is an increased rate of miscarriage, not recurrent pregnancy loss, but increased risk of miscarriage as well. So these are factors where we have to also remember that we have to start with her basic investigations initially, and then also, as Dr. Vipin
opinion, what basic investigations you like to do in this patient? Then I'll come down to
thyroid is one which I would definitely want to do. Her sugars is what I would want to do. I would obviously want to check her prolactin levels, her CBC, because her HB electrophoresis as well, and a rubella IgG is something that I do for patients, especially just to make sure that they have they are vaccinated or not. Other basic tests would be the viral markers and everything, which we would cover irrespective.
So, Dr. There is a problem now. She's having a BMI of 30, as Dr. Rohan was saying about the BMI. Now she's a 5 weeks of gestation with a fetal pole. Do you think at this particular point, when we do a HbA1c, what our Dr. Rohan is telling about, we have definitely going to do our HbA1c also. But if it is saying on a higher side, so what is your take on that? Whether you start with immediately on metformin, or do you do any other investigations before starting metformin, or any other?
But androgen levels can be checked, sir, because usually most of these patients who have PCOD, it has been linked to a recurrent miscarriage, especially due to the high androgen levels. So definitely, checking that, having an idea about her metabolic syndrome, if she has any other issues, usually they have also, thyroid dysfunction. They also have associated high prolactin levels. So all of them have to be checked to make sure they are all within normal limits.
Okay, so I'll go back to.
As she is already pregnant, whether it would be useful checking prolactin or androgen levels?
Yes, I think having an idea of the androgen levels would be definitely useful.
It will be on a higher side. You
Yeah.
cannot make a correlation of that prolactin during the pregnancy.
Yes.
So, ask Dr. Amol, if she is a PCOS, do you think that short luteal phase will be one of the cause that you'll think of having the recurrent abortions in the past?
Yes, absolutely.
Correct.
And our progesterone support should be good. At least dihydrogesterone twice a day.
To the hydrogesterone, what is the Lotus study and what is we can start with the which doses. But I'll definitely ask you one thing. If you wish to go with the progesterone, why not the natural progesterone and why not only the dihydrogesterone?
For me, there won't be any much difference. Either we are using natural micronized progesterone or dihydrogesterone. Basically, immunomodulation along with luteal phase support is the role which we want. And basically, we can even do a combination of dihydrogesterone with vaginal micronized progesterone.
Okay, so what is your aim at? Your aim is to increase the progesterone level, or your aim is to just to do a immunomodulation? Because
it should be both luteal phase support along with immunomodulation. So
your preference will be vaginal as well as oral.
No, I will. In this case, I would give dihydrogesterone twice a day.
Twice a day.
So I think I'll put up one comment over here. Since we don't know the history, because this is for this particular case only, since we don't know the history, don't know the investigation, what is the case is like, and at time there may be a combination of scenarios can happen. Means immunological factor along with a PCOS can be a factor. So let's give it a benefit of doubt and start with the dihydrogesterone, which can serve both of our purpose over here.
Now I'll ask Dr. Vipin. The dihydrogesterone comes with the different actions. See, the dihydrogesterone prepared by the chemical bending of the C12 arm of the dihydrogesterone. It comes with the ultraviolet bending of the C12 arm. So how you will suppose that definitely this dihydrogesterone causes immunomodulation and only the my poor vaginal progesterone, micronized progesterone will not do immunomodulation?
I don't go. I don't go into deeper into the pharmacology and pharmacodynamics and the physical action on it. But studies suggest that there is an immunomodulation possible cause. Maybe the possible effect can be there through the dihydrogesterone. And I'm not supporting dihydrogesterone per se as such, as Amol rightly said, any progesterone will work. But here, since in this particular case, since we don't know the history, we don't know the cause exactly, and that's why here I think dihydrogesterone may be a better choice than a vaginal or any other progesterone.
When you will start and up till what time you will going to give, and what is the dose?
So 10 milligram TDS or BD we can start depending, because BMI is high. We can give TDS also, and post 12 week up to, we can stop once the proper NT scan has been done. We can stop the.
Anyone wish to continue it till term? No,
I would.
You would. Okay. Yeah, there are
34 weeks.
So that's why I wish Rohan should say something so that both of us had gone to that particular paper. So it is you can definitely wish to till term. But what is the ideal way in your practice you'll do?
So in my practice, I think I'm going to agree with Dr. Amol and Dr. Vipin over here that I would also end up giving dihydrogesterone to these patients because of the immunomodulation effect. I think to continue it till 34 weeks is a little bit controversial because I think there are various studies regarding that. But at the same time, I think we like to err on the side of caution. So that's one reason why we do end up continuing dihydrogesterone. And it's supposed to be this, we all say that progesterone sometimes acts as a uterine relaxant as well. Even though the recurrent pregnancy loss we're talking about is in the first trimester, and generally in such cases, if you cross the first trimester, you don't expect any complications of a preterm delivery or a second trimester abortion. Of course, if there is any other cause, then I'm sure we'll be coming across the cases, I'm sure, later on. But I think we can discuss that then as well.
Amol, I'd like to know from you whether you would do their serum progesterone levels and then start with progesterone, or then decide possibly the dose. Is there any
No, not at all. Not at all. Not
dihydrogesterone does not
no role of
reflect
serum progesterone.
Yeah.
So no role as such as serum progesterone, but Rohan here, as you said that you supported the idea of continuing the dihydrogesterone for a longer time. Here, because we don't know the reason in this case, So if at all we have to prevent the preterm labor or anything, and just to continue the progesterone support, post 12 weeks, vaginal suppository and can be a better choice rather than continue, because dydrogesterone is a very costly affair, and and cost, if you want to consider cost effectiveness, in this case, dydrogesterone followed by vaginal suppository can be a better idea.
Sure. Yeah, so if we go into detail of the dydrogesterone molecular formula, Cmax and Tmax, what is important to know why dydrogesterone works better than other progesterone is that dydrogesterone has a more affinity towards the progesterone B receptors, which are present in endometrium and the decidual cells. And that is why the immunomodulation and the luteal-based support is better with dydrogesterone. And there's one paper which supports that till 34 weeks you can give safely dydrogesterone and it will support your pregnancy even if the concentration of your PRA and PRB receptors are less.
I think the only reason why you shouldn't continue dydrogesterone is just the cost factor, I think, more than anything else.
So suppose we are doing the IVF transfers in such a PCOS patient. We are going for the transfer, or maybe they are normal responders. So I just wanted to ask, just for a discussion, whether you start the progesterone at the day of pickup or at the day of transfers, or what is your strategy if it is IVF?
It will be always a freeze-all cycle in this patient, PCOS patient. It is going to be no question of starting progesterone at pickup.
When you do a fresh transfer, so whether you will start on the day of pickup or at the day of transfers, fresh cycle. I know we do it now.
If you are planning a fresh transfer, then of course it has to be progesterone has to be started on the day of pickup.
Anyone else?
Again, there is no question about it.
The day of pickup is if it's a fresh transfer.
Okay. Anyone else? Why I asked you, I'll just tell you my explanation. That's why.
No, sir. I would also start with the day of pickup only.
Okay. Usually, if you go to the literature and reviews of what they talked about, whenever it is a fresh transfer, I'm talking about fresh transfer in a normal responder. When you do a pickup, the corpus luteum, whatever they are going to form, will be taken care of for 3 days. So at the last, you can start. You can start little bit late also. It's not like all of us starts from the day of pickup. But if you wish to start it later also, the chances of implantation failure or maybe a pregnancy remains the same. So it will not affect as such the pregnancy rates, because there are the active corpus lutea which will produce the progesterone, which is taken care of. We'll discuss this already, that the pregnancy, some of us are very bold that we start the progesterone and we stop the progesterone at the time of the beta HCG positive or maybe pregnancy test positive. But now we are not that having said that all of these panelists will say, Rohan is already saying no. So it's fine. I understood. Till 12 weeks will continue. But at 34 weeks also, it's okay. I think there are certain studies that may say that Dr. Bipin is talking about the vaginal progesterone, definitely, because we don't want it to have a preterm labor, or maybe because if you compare the data of vaginal progesterone, it will coalescence the uterus and reduces the risk of preterm labor. We'll come down to the, this is the summary, this is the case now. This will start from Surakshit. The first pregnancy is female, 2.7 kg. She delivered that particular female child. Second pregnancy, 6 weeks, missed abortion. Third is 6 weeks, again missed abortion. Fourth pregnancy, 8-week retrochorionic bleed. Secondary RPL workup shows the TSH is 3.8. TPO antibodies is 529. Anti-TPO antibodies is 53. And she's on the Thyronorm, that is a Eltroxin 25, vitamin B6, 12, B12, and folic acid, LMWH. The fifth pregnancy is now she's pregnant. How will you manage? This is the profile of actual patient. Now the fifth pregnancy, she already has a first pregnancy, which was uneventful, delivered the normal vaginal delivery of 2.7. And after that, there was a repeated abortions with the history of particular thing.
Right, sir. Sir, for this particular case, since she already has, I think, may I know the age of the patient?
The age of the patient is 35.
35, right. So I think most probably for this particular case, we want the thyroid level to TSH levels to be maybe somewhere in the range of 2.5. So I think other than that, I don't see. I think this pregnancy and currently how many weeks she is, sir?
It's 5 weeks again.
5
Because
weeks.
she's
And
now
heartbeat
having a
was
6 weeks pregnancy losses. So she came up little bit early. And we
right, sir.
documented the 5 weeks pregnancy with the fetal pole inside.
Fetal pole, but no heartbeat was not yet recognized.
Because we had to wait for another 10 days.
Right, sir. So yeah, for this particular case, I think definitely I will start her off on progesterone if she's not already on progesterone, and aspirin and low molecular weight heparin. These are the three things. And other than that,
Already she's on thyroid tablets. Already she's on. Yes. Yeah. So,
So her APTT is seems to be on the higher side. What was the range? It's looking on the higher side.
it is APT on the higher side. Thyroid antibodies is a little bit raised. It's much more raised. If you can.
So, was a lupus test done?
Lupus has not been tested. It's not been done. But already she's on LMWH. You can see.
Yeah, fair enough. I think the APTT
for the audience, even if we do a lupus anticoagulant, the treatment remains the same. So already she's on the masala, so that is already been taken care of.
So there are a few more things also we can add to the masala which are missing. Everyone's recipe is always a little bit.
Everyone's
more
recipe is
mix
different.
and more masala.
Recipe and our recipes are totally different. Yes. Tell me.
So with the APTT race, I think maybe look, honestly, with the treatment that's on, we're pretty much covering all the possible causes, including, as Surakshit said, that we're going to be starting progesterone for her as well. And I'm sure it's already been started. At this point, you're just honestly also keeping your fingers crossed because you have started everything that you wanted. The APTT being raised is going to give me a little bit of an inkling towards the thromboembolic factor as well, where that could be my concern.
But it is a little bit increased, and she's pregnant. So that is another way. I will not think of that much because LMWH has already been started. So
we've done these investigations after she's pregnant.
Yeah, after she's pregnant because she was on thyroid, 25 milligram. So I will ask Dr. Amog. So all these things, she has been pregnant, and now little bit APTT. What we are talking about is little bit higher. Anyhow, in a pregnancy is hypercoagulable state, so will not. Maybe we can thought of the reason, but now we cannot. It is not in our hand to investigate for the lupus or something like that.
Right.
So in this particular phenomena, anything else you wish to take into account?
So I would like to up the dose for thyroxine, maybe increase it to 37.5.
How
that
you will monitor the thyroid in pregnancy?
So in my practice, patient whose first investigation shows hypothyroidism, I monitor every 15 days.
Okay.
TSH levels, and I also do a free T3 T4 level.
You do a T3 T4 free.
Free T3 T4 I do along with TSH. So according to that, I manage the doses. Another thing that you need to take care is that the thyroid antibody is slightly on a higher side. That indicates an autoimmune component to the patient. So I would like to start her on maybe prednisolone. If her BMI is depending on her BMI, I would adjust the dose of prednisolone for this patient. And maybe if now we are trying everything, so maybe intralipids also I will try to be given every 35 days.
Okay, so my question to Dr. Vipin, they are already talking about increment of the thyroid dose. The thyroid antibodies are a little bit on a higher side. He already started on a Visolon, and now the thyroid thyroxine, L-troxin has been increased. What is your range of a thyroid that we are looking at? It is a 3.8. So you are satisfied of doing the TSH after 15 days immediately, or you will wait for some time?
Ashish, first of all, whenever if this patient has come up at this stage only, then it's a different scenario. But if someone is already following this one, then this patient should be the doses of the thyroxine should be tweaked a little bit, and I would have uplifted the thyroxine dose to 37.5 because as the pregnancy increases, you have to increase the dose by at least 25%. That's most of the studies say. And considering that the TPO antibodies and the TSH are on higher side, the thyroxine need to be upgraded. Now here, what should be the level of TSH? I would prefer to have a less than 2.5 to be on a safer side.
Okay, so
to repeat it, I think repeating every 15 days, it could quite exhaustive. So I'll reserve my opinion. I'll do TSH, repeat TSH only after a month. So
after a month, absolutely, I can say that that's a good way, good clinical practice to see the TSH maybe after a couple of days later, because 15 days. See, she is having a TSH on a higher side and TPO antibodies on a higher side. It will take some time. If it is only a TSH is high and T4 is normal, then definitely we can correct it and just see after 15 days it is working or not. Yes. So if you are TPO, yeah, someone else wish to talk. So these are the prevalence of the thyroid autoantibodies positive. So some of them are correlated with the titers and unlikely to be a casual. Antibodies has its own functions and it has been necessary. I already asked about the follow-up of this patient. So she is a 5 weeks pregnancy. We all of us know that 7 weeks we are a little bit worried about having that cardiac activity coming or not. As Amok was saying that after 15 days we'll definitely call her up. He will do the TSH and will do the scan. And after the scan, see what is anyone can collaborate. What is the CRL and the gestational age? What is the, because we are also worried about the auto antibodies causing the effect of the growth, and that is the one of the things that one should be remembrance about. What is the CRL correspondence to the gestational age? If anyone knows about in depth, we'll discuss, or otherwise just keep it that later on.
So by 11 weeks, by 11 to 12 weeks, it should be somewhere around 45 millimeters.
Yeah, that is what we take for a NT scan. I'm talking about a CRL and 6 week CRL, because see, the TSH is a dynamic hormone we required for the growth. We required for another thing is for the, see, T4 is normal. That's why I asked you whether we do a T4 or T3. Free T4 and T3 is later on in the pregnancy, maybe at 28 weeks and later. We required it much more as an importance for T4 rather than a T3 and TSH. Because if the T4 is late, so what you call as a the intellectual part of the baby is going to get affected. So that is the one of the things that one should be taken into account. So we'll come down to our now endoscopic fellows, and I think Surakshit will be now happy to just to fast and everything will be done and we'll out of it. So we'll done. We know the karyotyping. I will not go into the mutation and all that thing. So we've done all the evaluation. When you think that uterine anatomy plays a role, at what period of gestation if there is a recurrent pregnancy loss?
Yes, sir. For most of the patients, if you see, the uterine anomalies are the cervical incompetence is what I see the highest, and so usually it comes on the second trimester. In the first trimester, even though most of these cases who have RPL, sometimes, we do definitely go ahead and do a histoscopy. Around 30% of patients, we find some kind of defect, like a small septum or, subseptum we see, so that we correct it and it should be fine. It also works like an endometrial
question. My $1 billion question to you: whether you correct the subseptum or you leave it? Honest to everyone, because I asked the same question to Amol also and Amok also, and then Rohan also, and Vipin also.
It's so difficult not to take the scissors when you see the septum, no? So we do end up, nicking it off and making the cavity whole again. Yes, sir.
So, Dr. Amol, when you stop of cutting the septum, when you think it is done, I will not cut more.
So when we resect the septum, it has to be, there should be some undercorrection. So when we start seeing the pinkish myometrial fibers, that is the time to stop. Always keep the ostia in your vision, so that you understand and you do not go on to perforate the uterus. And it's such a simple procedure without any complication, daycare procedure. I don't think that in a patient with RPL, either a subseptate or a partial septate uterus we should not resect. We should definitely resect the septum.
So my question to Dr. Amog, if in which condition you will use a electro surgical unit for the resection, and which cases you will use scissors for the septoplasty?
So if you ask me personally, for all my cases, I use a scissor. And if at all there is a broad-based septum which shows high vascularity on an ultrasound, a fibromuscular septum which shows a little bit more vascularity at the base, I use a 5 French electrode for just cauterizing the blood vessels and continue with scissors. But if you ask according to the practices, a broad-based septum or a complete septum, a resectoscope would be a better option.
So my question to Rohan, if you do a resection of the septum, do you advise the patient for just to take a gap, or she can have the pregnancy immediately in a coming month?
Okay, now it all again depends on how much of the septum you've cut, and again what kind of approach you've taken as well, whether you've done it with cold scissors or you've done it with electrocautery. I think when we are using an electrocautery, I think most of us would think about doing a relook hysteroscopy maybe after 4 to 6 weeks, just to ensure that there are no adhesions. And generally, I would tell the patient, if it's a small septum, I would just ask the patient maybe that same cycle of hysteroscopy just to take a break and maybe try immediately after a month's break, if it's a small septum.
So my question to Dr. Vipin, when you cut the septum and next time she come up with again with the abortion, and she will say, sir, you had done the septum correction, you said this is the culprit, I had done removal of the things, I'm the best, but still I'm having the abortion. What is your counseling? What you talk to the patient? See, okay, Baba, I had done everything, but still, tera nasib, mera nasib hai. Kya karenge abhi?
So, Ashish, at the beginning of, since we started jumping on the medical part, but the counseling is one very important, which we all have forgotten. And discussing any case about RPL should start within the counseling, because counseling will play a major role. And I think we need to understand, make the patient understand and the relative understand that this is just, I'm excluding one of the cause, but there can be multiple causes which I'm not ruling out right now, but they may they may affect your pregnancy. And abortion is, even if you are a recurrent pregnancy losses, fortunately, unfortunately, you may end up in for an abortion, which may not be the cause for your, may not be the cause right now, but may have a different cause in the subsequent pregnancies. So we have to have a very detailed counseling about various causes, and then we have to go forward.
Why I ask this, Vipin? Because now there is called as trust trial, which
Yes.
definitely shows us a contradictory statement. They say that the septum resection doesn't improve the pregnancy rates. So that is basically a totally a paradigm shift, that whether to cut the septum or resect the septum. There's a two school of thought. Some of them just resect the septum or divide the septum. Some of them just do a septum complete excision of the septum. But whatever you will do, the multicentric study that is called as trust study, which comes up, we said that there is no evidence that particular septum correction will increase your live birth rate. So that is the one of the things that one should be taken into account. So I'll just ask Nishad, because he is now quite as not having his say up till now. Nishad, when you suggest the patient about HSG, she said, "I had done the HSG, sir. Why you wanted to do a hysteroscopy in myself?" Do you have any say to say no? I will do a hysteroscopy even if your HSG is normal, or you will say no, it's fine. HSG is fine. I will not do a hysteroscopy.
See, at our clinic, we actually believe in going for hysteroscopy for the patient. So
he will do it for every patient.
Yeah. So that I leave it to Amok to take care of. So that way, that way we manage the stuff. So mostly it's, yeah, HSG, I mean, it is good, but definitely hysteroscopy, even the basic diagnostic one, it gives you a better idea of everything else and clarity, and as well as the video. So it does make more sense to me. So going for a hysteroscopy than in just a normal HSG.
So you can actually rule out chronic endometritis when you do a hysteroscopy rather than an HSG, and that can be another cause of implantation failure, which may be that, and also RPL. So hysteroscopy would trump over HSG any day.
Okay, can you just elaborate what are the signs you will see in chronic endometritis?
Yeah, so in chronic endometritis, you will see micropolyps, you will see strawberry gland lesions, you will see open glandular pattern which appears yellowish in color. You will see some flimsy adhesions can also be some flimsy adhesions are also seen. Fibrosis can be seen at the lateral walls mostly in such cases, and many a times on the lateral wall there appears to be a small kind of a concentric band that you see in chronic endometritis because of repeated trauma or injury or infection at that particular area, because that is one of the most affected areas that I have observed during a hysteroscopy in patients of chronic endometritis. And when I take a biopsy from this particular region, the CD138 is always on a higher side, indicating that it is a chronic endometriotic patch.
Okay, so I just want to ask now, Surakshit, that whenever you are putting the hysteroscope, what actually you will start doing there is a two ways we do it. We do it vaginoscopy and then we'll go a hysteroscopy. So can you just silently tell our audience what you will see and how you will proceed for vaginoscopy and then into the hysteroscopy as far as the RPL is considered? Any factors you will be able to just pick it up when you do a vaginoscopy, when you do a cervical canal? What are the things you will look at?
Right. So when we're looking at vaginoscopy, I think mostly we'll only have an idea whether there's a hypertrophic cervix or not. That's something we can see. You can always have a look at the ectropion, which is also clearly visible. But again, going through the cervix, the canal, usually we won't pick up much. But again, I think once we're inside the cavity, we'll be able to have more information. But I think, at the cervix, maybe if she has any cervicitis or if there's a hypertrophic cervix or there's an ectropion, definitely we'll be able to pick it up, sir.
Okay, so Rohan, can you just tell me if I'm having a 3D ultrasonography, I'm having a like a good hysteroscopic surgery as an asset to me. So whether you've seen a comparative study between the 3D ultrasonography, hysterosalpingography, and the hysteroscopy, which will tell me about the causes of a recurrent pregnancy loss. Because if we have, which is one of the thing is office procedure, another thing is non-invasive, doesn't require anything. So what is your take on the particular modality of diagnosis?
Sorry. So I think when we're looking at a case of recurrent pregnancy loss, I think I would end up going with the hysteroscopy to rule out the anatomy, because at the same time you're visualizing and being able to treat as well. But I think a 3D sonography, especially with the kind of machines that are available right now, the resolution is good. You're able to get high quality images, and the 3D construction as well of the images is so beautiful that you're able to pick up if there is any anatomical cause or not. So especially when you're doing these with a 3D scan, in fact, there have been now multiple studies. In fact, I just did a debate at ISAR on hysteroscopy or not for all IVF patients. So in that we came across multiple studies which are saying that the USG, especially the 3D USG with the kind of machines, is equivalently good. But if you see a anomaly, then definitely go ahead and treat it with a hysteroscopy. Another thing is that, especially if you're looking at a bicornuate uterus or a septate uterus, a hysteroscopy alone may not be able to point that out. You may have to take the assistance of a sonography, and especially with the 3D scans now, you can easily differentiate and plan your treatment as per that. So I think a 3D ultrasound is a must, I think, for every case. And then a hysteroscopy, I think everyone on this panel will probably agree that if you have a recurrent pregnancy loss case, you're going to do a hysteroscopy. As I have already talked about chronic endometritis, we would also want to rule out tuberculosis as well at the same time, because in India, we do have a high number of cases of tuberculosis. So that's also something that we would look out, especially in that.
Amol, what is your take, Amol, that's when you do a hysteroscopy, what will affect, what is the improvement that you will see? See, in some patients, you just do a hysteroscopy and chances of pregnancy continuation is high, even if you not do much more about it. Do you think that doing the hysteroscopy will be an asset of improving your endometrial milieu, or maybe you are washing out of the some of the factors that you are thinking of?
So definitely, first thing is, as everybody will agree that hysteroscopy is gold standard for diagnosis. Second advantage is we not only diagnose but simultaneously treat. And as you said that if suppose no lesion is found out, we at least rule out endometrial tuberculosis, and sometimes even just that endometrial scratch itself helps in giving a better pregnancy outcome in the subsequent pregnancy. So that will be the role.
Ashish and rest all panelists, I have one comment over here. I have a different take on whether to do HSG, whether to do SIS or a 3D or a histro. All these are good, but I always take a decision if it's an early trimester abortion or RIF. Then instead of just doing hysteroscopy, I'll always go for a diagnostic lab, because if it is tubal pathologies or tubes are indurated, or there is a pelvic pathologies, adnexal pathologies, which may end up in aborting early abortions. But if it is in a second trimester or early not an early trimester abortions, then definitely hysteroscopy or 3D sonography is enough to rule out the causes.
So, Vipin, do you think that when you put the laparoscope, you will find out the pelvic pathology? What do you mean by it? The early stage endometriosis will be one of the factors that you will take into account?
Because see, Ashish, we are into IF industry. We know that to us more our RIF patients come than RPL, and then for those patients having means affected tubes may end up in a recurrent implantation. So a lot of studies have shown prophylactic delinking of the tubes is having an advantage in those cases. So I'm saying in that perspective. So if it is an early trimester abortions history, then definitely diagnostic lab will have serves better than hysteroscopy.
Yeah. So just to go back, when you're talking about the any of the adhesions, or maybe there is a Asherman syndrome, I'd like to ask the Surakshit, whenever you are doing the adhesiolysis, what is your modality of the treatment? Whether it is always associated with the laparoscopic view, or just you go with the hysteroscopic adhesiolysis, and post-operative care for that matter.
Right. So for these patients, usually we always have it along with the laparoscope as well, because we want to see if there's any tubal pathology. Because most of the time we see that if they have some uterine adhesions or synechiae, they do also have some tubal pathology. So for that we go ahead and have a look, sir. Otherwise, as far as energy source, we don't use any energy at all. We want to only go ahead with scissors, because any kind of energy we use, it is going to definitely cause that synechiae to come back again, and we will have more issues. And recently we started using the small a silicone balloon which they have been giving us. We just place it inside and then we come out, so ideally the cavity remains the same. We stopped using IUCDs which we used to use before. Now only this one we are using, sir.
Among using something estrogen, progesterone, or you will just do a adhesion biology?
So for in cases of Asherman's, I go in with a cold scissor, incise the adhesions, do an adhesiolysis, complete adhesiolysis, and put a number 8 Foley's and inflate it with around 2.5 to 3 cc's of distilled water. And along with that, I give high doses of estrogen as well. Remove the catheter on day 3 post-op.
Okay. And what about the post, like when you are going to collar up, or whether you will really do a relook hysteroscopy?
So what my practice is, instead of going for a relook hysteroscopy, I would rather do a sonosalpingography.
Okay.
With the 3D sonosalpingography.
Anyone
else?
That
will give me a better reconstruction
from the view. Everyone is
Ashish, in this case, and the case where Seneca is there, and we need to cut down under the Seneca case, we don't have to wait, because these are the patients who have a problem with endometrium. So what Amog has said, I want to add on this. These days, what we are doing is, we are doing on the day of hysteroscopy, we are giving it a GCSF, and then doing installation of a PRP on day 1, day 3, and day 5, and then putting them on a high estrogens and calling them back on
when you do a day 3, day 5 hysteroscopy, you will do a transvaginal ultrasonographic guided, you do PRP.
Transvaginal. Yeah, absolutely. And this is giving us a very good result in those cases where Seneca is there.
So I think I was talking about, then coming down to the cost, because in India, what we talk about is the cost. So if many of the patient of the recurrent pregnancy loss come down to us, we'll say, like Surakshit will say, I have an office hysteroscopy, it is the office procedure. But they'll say, so it's okay, but the cost that matters. You will charge me for that particular scope to be inside, and then sterilization and all that thing. So what is your take? What do you talk as a counseling part for the patient? Yes, Amol. After Surakshit, I will come back to you.
Sir, for these cases, usually I don't think office cystoscopy has big value in India, because I think mainly when it comes to cost factor, it's more in the US and UK where, the costs go very high. For us, I think, when you're looking at office cystoscopy, I think it's more costly than doing a regular hystoscopy. So I would definitely say, I wouldn't really look at office hystoscopy at all, sir. I'd just definitely go in for hystoscopy. I wouldn't counsel for.
I think a clear take-home message should be that HSG has no role. Basically, we should redundant HSG. If you want to just say screen out a patient, then a good 2D, 3D scan and just a saline infusion sonography would be a very good thing. Of course, hysteroscopy is the gold standard. It is a gold standard not only for diagnosis but also gives a simultaneous correction. HSG has so many drawbacks: radiation exposure, use of dye. Basically, it does not give us a dynamic evaluation of the whole cavity unless we do HSG under fluoroscopy guidance. So comparing HSG with a saline infusion sonography, we should always prefer a saline infusion sonography.
Well said, Amol. It's a really good take-home message. So I'll pass on to the panel to my wife. So she will ask last embryological point of view.
I think I'd like to ask Nishad from the embryological point of view, how important it is regarding semen analysis play in the RPL. I mean, would you think that doing a good semen analysis would be important, and what parameters would be important as far as
RPL? Definitely. Male factor has a very important role here in RPL. There is no doubt, as I mentioned earlier also, that DNA fragmentation index is another factor, because that can lead to aneuploidy, and aneuploidy can lead to RPLs and RIF. And like even if it is implantation happens, the RPL can happen with cases where especially if the patient, if you have not taken a proper history, patient turns out to be a heavy smoker or heavy drinker and lifestyle problems. So DAFI is, I would not use the word gold standard, but in such patient, yes, it is very essential to go for DFI, and you can have your own standardization and then determine, because this will help you in counseling the patient according to lifestyle factor to decrease or their DFI and get better. Because see, blastocyst morphometrically can look good. It is not necessary that genotypically normal. Second factor is, with even such parameters, the embryo can grow faster or slower. So these factors also has to be considered in RPL, because a normal morphometric analysis, morphokinetics, that is the speed at which the embryo grows, is important. A faster growing or a slower growing. It is also dependent on the quality of the sperm as well as the oocyte. But since we are talking about the sperm, yes, with DFI, you have to consider that in such cases, the quality or the speed at which the blastocyst is forming or the embryo is growing will be less. So that is a correlation to a higher extent. Maybe you can call it a concordance of 70-75%, where RPL can happen. So you have to go in for DFI in such patients. Yes, motility, stenosis permia, SOAT, yes, it is a factor, but DFI is more important than just doing the semen analysis.
These patients of RPL is that they conceive on their own. So maybe it is also important for the clinicians or the general gynacs also to understand that even if the patient may have a normal semen analysis, doing DFI is worth it, because even a normal semen analysis would have a higher DFI. That could be a cause, one of the cause maybe of the recurrent pregnancy loss. And Nishad, anything else that you think is important as far as doing ICSI versus an IVF is important if these patients come in for doing an IVF?
Ashwini,
yeah,
I mean, Nishad, just before you answer that, ma'am, there's actually a new concept of a paper which was published for recurrent pregnancy loss, which talked about paternal aging. We know that maternal aging already does cause, because of the oocyte quality, advanced stage, there's more effect of a genetic factor. But now there's a concept of paternal aging where as the male age increases, the sperm mitochondria are also affected, which can cause an increased risk in RPL as well.
Birth defects have actually been pointed out to the paternal aging also.
I think Rohan, you've mentioned a wonderful point, and I'm to club both Ashwini's and yours point here that she mentioned about IVF and ICSI. So what we have started doing is the patient age is more than 39. Straightforward, whether DFI is good or not, semen analysis is good or not, straightforward ICSI. If it is less, then we actually see the parameters and then go in for IVF if the DFI is less. So that is what we have done. So yes, IVF is still slightly where nature gets to select it. So I would rather prefer IVF any day over ICSI. But in cases where you know that with higher DFIs and higher age, even in the male, we have to go for ICSI, then yes, that will be the thing that you'll have to manage.
Ashwini and Ashish, I want to make one last comment because I have to rush otherwise. Yeah, DFI, Nishad has definitely told that DFI has to be done, but DFI is done, that's okay. But we need to, we always forgot that the RPL, as a lot of panelists have said, the RPL in male factor can be a major cause. So DFI is just giving us an idea whether there are multiple factors which can causing this DFI. So if DFI is high, we have to rule out the modifiable causes. So we have to do the thyroid, we have to do the diabetics assessment, we have to do the local examination whether varicocele is there or not. Endocrinologies, other factors also we have to rule out. So infection. So all these things, once you know that DFI is high, all these causes has to be ruled out. If the grade 2 varicocele and all those things stuffs are there, we have to do the corrections over there also.
Vipin, I may ask you one thing. If the DFI is high, what is the implication? We'll have a embryo quality which is anyway going to be bad. So what makes a if the DFI all of us are talking here, like due respect to embryologist and Nishad also, but what exactly we carry home? Carry home is the same thing that you just wanted to talk to your patient. Your DFI is one of the reason you will find it out because of your much more knowledgeable and talk to him. This is the reason that you are.
That's what I'm saying, that we have once the DFI is high, we need to assess the male partner also and do rule out whether the thyroid is the cause, whether the infection is the cause, whether diabetes is the cause, whether the other endocrine pathology is the cause, or the local physical infection or varicocele are the cause. And if ruling correcting those can RPL, I don't know, but because there is not such much major studies over there, but RIF definitely will have an improvement.
See, what is important is, we need to tell the patient, especially in case of RPL, that lifestyle modification is your key. I mean, DFI is just a diagnostic tool for us, but really paving that some patient timing and everything, and then counseling properly is the key, where your DFI will fall and then do all the processes. There's no point rushing into doing IVF and ICSI and just making blastocysts and transferring. Doesn't make sense there.
Okay, so just only 2 minutes. We'll take a one take-home message as far as the RPL is considered. So we'll start from Dr. Vipin, then we'll go with the Nishad, Rohan, Amog, and Surakshit, and Amol. One take home message.
The take home message from me, that do a proper counseling, give the positive vibes to the patient, that is still there is a good chance that you will conceive and will have a healthy baby at the end. And that's very important. Yeah.
Right. Two things. Morphokinetics are very important. Always study the speed at which the embryo is growing before you transfer. It should be at normal rate. One. And
It should have an IVF pregnancy.
Yeah. Hopefully, in such cases, yes, that will be the case.
I think I'm just going to reiterate the fact that my mother always says that TLC should be the priority when it comes to any of the RPL patients, tender loving care. And I think, as Dr. Vipin said, counseling is of utmost importance. And I think at this point, we've reached a point, especially even in reproductive medicine, that we have a lot of technologies which can help us bypass at least the identifiable causes of RPL. So we should look into those. Yes, I understand cost being a factor, but we should give all the options to the patient and let them choose them.
Yes, Surakshit?
Yes, absolutely. I think it's very important that we involve the patient in the decision making, because that way they also have the confidence in you and they're also well informed about all the procedures we are doing. Because at the end of the day, you cannot take all the blame, because, it becomes like a complete blame game otherwise. So I think, as Rohan said, it's very important that we need to include the patient, inform them all the various options and start giving them the treatment as such.
Yeah. So first of all, listen to the patient. Let them cry their heart out completely, and pick up the important points that they'll tell you. And then do specific investigation to rule out particular causes. Don't overexpend. Don't do blanket investigation for all. The patient is telling you his story, and there are clues in it. Search for them and do targeted investigation.
Okay, Amol?
Basically, we have to differentiate first trimester losses from second or late trimester losses, and investigation, we have to rule out anatomical causes, we have to rule out genetic causes, we have to rule out endocrinological, immunological causes, and any cause if we get, we have to treat it, and then only allow the patient or tell the patient to go for the next pregnancy. It should be preferably a planned pregnancy with preconceptional folic acid, aspirin, and any cause which we have got should be corrected. And at the end, the patient should know that even after 3 consecutive pregnancy losses, the chance of having the 4th pregnancy as a take-home healthy baby is going to be very good, more than, you can say, around 70% or so. So that positivity should go with the patient, so that
Thank you from both the Kales to both Chimotes and Rohan, Vipin, Amol and Surakshit. We have really enjoyed this panel, and I'm really thankful to Dr. Komal, Dr. Ritu, and Dr. Sheetal for having us on this panel. Thank you very much. See you again.
I would like to say thank you to Komal ma'am, and Komal ma'am, I wish you all the best for your vice presidential elections of Foxy as well. Wish you all the best, ma'am.
Yeah, thank you, Rohan. Thank you so much for your wishes. And I think you both are there, even we both are there in the same, but the light is not good. So Niranjan and me are also on the same screen as Ashish and Ashwini are there. So Niranjan also will say hi to everybody.
It's Chavan's to
everyone. So thank you. So we have even to join you, even we are there. So there are 3 hat-trick here going on. So
it's a unique webinar.
Yeah, unique webinar.
So ma'am, you have to give credit to me and Ritu for choosing everyone.
Yes. I think Ritu and Sheetal have done like fabulous work.
Very good job.
Very good job, and really applauds to all of you. Thank you all. Thank you so much. Thank you. Bye.
Thank you everyone for the wonderful panel. It was really amazing. You all have covered all the points. So thank you so much, everyone.
Thank you, Ritu. Thank you.
Thank you, everyone. Thank you. Good night.
Thank you, Dr. Vipin.
Thank you,
Dr. Amol,
bye.
Trupti, Dr. Surakshit, and Chimote brothers. Yeah.
Thank you.
Bye, Dr.
Thank you.
Yes.
Bye. Ashish and Ashwini.
Nice meeting. Bye.